welcome to all of you for the day two of deep dive into breast cancer treatment discussion. That's on ESMO Breast 2025 and ASCO 2025. So we had a lovely day one, which where we discussed all the important abstracts and the updates that were there in the last probably 2 months in the field of early breast cancer, hormone positive, HER2 positive, and triple negative, and definitely the highlight of the day one was the statistics session by Dr. Sendil Rajappa, and we learned I hope all of us would have become better on how could we interpret a non-inferiority trial. So now we move on to the day two, which has actually technically has more important abstracts to be discussed, and we would be having three moderations, and the last of that will be the best five picks of Dr. Sendil. Again, we have asked him to pick his best five picks from day one and day two, and he will be picking up five abstracts what he feel would be potentially practice changing in the day of day one and day two. So without much of a delay, before I start, I would just like to thank all the faculties and all the team support which has been there so that we could do this. And the best part is there is no company influence and interference, so it becomes a real discussion for what we as doctors want, as oncologists want. So Dr. Vamsi will be moderating the first session, and Vamsi, I see all your four panelists there. I can see Somyo has joined in. Hi Somyo, welcome. He's from Bhubaneswar. Nitin, our young guy, a dynamic medical oncologist from Bangalore, and we have KP who will be also moderating the last panel discussion from Bangalore, and we have Vishwajit from JIPMA. So please, Vamsi.
Good evening, everyone, and welcome to all my panelists. It's always nice to have a discussion on some new things. Often these new things are probably what we'll be practicing a bit later, which is fine. It's always good to learn. But I would also, obviously, at the end of my discussion, talk of what is the... Okay, one second. Yeah, I would also be at the end discussing what we can do in India. So we have around 35 minutes to go. Request the tech team to just let me know 5 minutes before stopping, so before my end, so that I can discuss the last slides more importantly. So what I'll do is I'll jump straight ahead to the topic of discussion. We are talking of HR positive metastatic carcinoma breast. And the way I look at it is, we have three distinct subtypes. You have a metastatic treatment naive, which means the patient has not received any treatment so far, has come to you with a fresh diagnosis of HR positive metastatic breast cancer. Could be an endocrine sensitive or an endocrine resistant, which means that the patient has been on treatment with endocrine therapy and has now progressed either on treatment or within 6 months of ending or after 1 year. That's the general definition which is being followed, and I'll stick to those definitions as we discuss. So the first question to all my panelists is, let's go one by one, and we will ask, starting from Dr. Soumya. Dr. Soumya, do you routinely test for PIK3, AKT and all at progression in a case of metastatic breast cancer, and do you test it at baseline? Dr. Soumya.
So I do only PIK3. I'm not able to do a ESR1 or the AKT pathway. Only PIK3.
Okay. Only PIK3 you're doing. Very honest answer. Dr. KP, would you do both? Would you do all three? Would you not do? And when would you do it?
Yeah, previously I used to do only PIK3. Now I've started doing ESR1 mutation as well.
Okay. And you do this at progression?
At progression, after first line.
Basically, if you're endocrine resistant, but basically on endocrine therapy or after first line metastatic therapy, if I understand.
Agree.
Okay, perfect. Dr. Nitin, do you do the same?
Yeah, so not for patients who are metastatic treatment naive disease, but if someone has
again,
a sort of
after first line. And
not only after first, like for example, someone has finished adjuvant therapy and has relapsed, let's say in 1 year or 2 years.
That's endocrine sensitive. Yeah. That's what we meant.
Yeah. So even in them we would do it. I'm not doing it in the metastatic naive, but again, like KP sir said, both PIK3 and ESR is being done.
PIK3 and ASR test. Excellent.
Yes.
Dr. Vishwajit sir, I mean, I understand where you're practicing. So would you be at least wanting to do it in everybody? I understand there are issues of finances always, which I think for today's we will not discuss. But would you like to do it for everybody? And second question for you would be, would you test liquid, that is ctDNA? Would you test tissue, or would you test both?
So pick 3, because the company sometimes provides free, so we are able to test in most of them at least.
Yeah.
And it's mainly from the tissue. If the tissue is not okay, then in the liquid, but not upfront, only in when the
at progression. That's what everyone has said. But you would like to test on the tissue, not the liquid. Very good. So again, there's a reason why I'm asking this, and I'll take it from the next slide. If a patient has a PIK3 mutant endocrine resistant disease and an endocrine sensitive disease, what would you do? So Dr. Bishwajit, in your practice, you have done a PIK3 testing, it has come mutant, patient is endocrine resistant, scenario 1, patient is endocrine sensitive, what would you do?
You're asking about the treatment?
Yes, yes.
Yeah, treatment and in the first line.
No, you have done PIK3 after first line. That's what everyone said. You're not going to do it at first line, right? So
after first line, if there is a PIK3 mutant endocrine resistant, then I would suggest and offer alpelisib with fulvestrant.
Okay. Alpelisib, fulvestrant would be your option. Very good. Dr. Nitin?
Yeah, same thing here. If a patient has progressed on a CDK4/6 and AI, we would go with alpelisib and fulvestrant.
Okay. Dr. KP, how many people actually take alpelisib? Again, forgetting the cost aside, it's not an easy drug to use. As someone told me recently, we all don't want to use it, but we are forced to use it. But what's your take on that?
Yeah, I think it's an extremely difficult drug to give. The hyperglycemia is very, very difficult to manage.
Excellent.
In addition, there is some issue in getting the drug sometimes.
Yeah. Fine. So that I have established the background for the first study that we'll be discussing. This was the INAVO 120. Now, this is a phase 3 study which has been presented earlier. The NEJM paper actually came out in October 24. This was the final overall survival analysis. Now, just a couple of slides on what the study is. The study is first line, inavolisib, placebo versus inavolisib, palbociclib plus fulvestrant. This is PIK3 mutated patients who are endocrine resistant. Okay, this is not endocrine sensitive, this is endocrine resistant patients who are having this combination of a triplet drug. Now, the patients actually were tested either by tissue or ctDNA. Interestingly, 90% of patients were tested only by liquid biopsy. They were not tested on solid. So that's just what the trial did. Now, these patients had progression during or within 12 months. That's the classic definition of endocrine resistance. And here is one thing, that the fasting plasma glucose has to be less than 126 and HbA1c less than 6. This is the standard for even alpelisib. This is what they did. And they combined 3 drugs. They gave fulvestrant, palbociclib, and inavolisib. Right? So all patients should have PIK3, and they combined 3 drugs together with palbociclib. When you looked at the patient status, 40% were actually premenopausal, and tamoxifen was received only by 50% of patients. Now, the reason I'm asking this is, how common is this in our routine practice? Are we all practicing only tamoxifen, or are we all shifted toward OS plus tamoxifen or OS plus letrozole? Dr. Soumya, in your practice, if a patient comes with HR positive disease, are we still giving only tamoxifen as a routine for premenopausal, or are you giving suppression?
No, for patients who are having a high tumor burden, I usually prefer tamoxifen plus OS.
Right. So percentage wise, Dr. Bishwajit, how many patients would be only on tamoxifen nowadays? Obviously premenopausal women.
Actually, we give it only for the high risk group, which is 30 to 40. In that, most of them, either they they get OFS.
Yeah.
Or we sometimes, if they're completed family, we sometimes also offer oophorectomy.
Oophorectomy. Perfect. So this is one thing which is different from the trial, again done 10 years back. So probably in our practice, this may not be what we will see, but then again, I don't think it really makes a huge difference. Now, this is the progression-free survival. And as you can see, the stratified hazard ratio is 0.43 with a p-value of 0.001. Okay, nice separation of the curves. The curves separate very early. They keep on separating. And the trial actually needed a hazard ratio of 0.65. So this trial pretty much comfortably met that endpoint. Now, this is the subgroup analysis, and it seems to work everywhere. Small outliers like this were there, but I don't think that matters. It seems to work everywhere. This was the initial overall survival that was in the NEJM paper that I spoke about, with the hazard ratio of 0.64, slightly close to the unity, but fair enough. And the final report was this. This was what presented in ASCO 25. The median OS was 34 months versus 27 months. So very significant difference. It's almost 7 months difference, with a hazard ratio also pretty significant. The hazard ratio was around 0.67. So a decent number. So again, starting from my panelist, this time from Dr. KP, what's your thoughts on the trial design, and do you think it can be applied for all these subsets, or do you want to restrict it to any subset?
Yeah, I think this is going to be not very easy to deliver. So I think patients with a very high-risk disease, large tumor burden, young patients, I would think about it, not for everybody.
Okay, you would use this for only young patients. Any reason for that? I mean, Ivanosertib seems okay. There is a fulvestrant which is well tolerated. Palbo, we know it is well tolerated. Would you still want to restrict it? It seems to work everywhere because.
It seems, but it also, would be quite toxic in patients. From whatever experience we have with alpelisib, even though it might be better tolerated than that, I think still it would be quite toxic. Unless we have really hands-on experience, I would be a little wary of starting it in everybody.
Okay, very good. That's one approach. Dr. Soumya, your thoughts on this trial design? They have restricted this drug. Now, inavolisib is actually a PIK3 P110 alpha specific inhibitor. So it actually is supposed to have less side effects because it's a very specific isoform of alpha inhibitor. So, Soumya, your thoughts on the study? I mean, would they have been probably better off just involving everybody rather than restricting it to the endocrine resistant subgroup?
The results looks very good. The tail is actually looks very good. The tail. The problem is that again I was very happy with the solar one, and then we had this stomatitis and the hyperglycemia. So once we use that, probably will be knowing better. So hyperglycemia, stomatitis, mucosal inflammation, and this dry eyes thing that is still there. So probably once we use that, we'll know that. But the results looks good.
The solar one just about got OS. You know, you had to do all this jugglery with the subset, look at PIK3 alone, all that things happened. But here the OS seems to be pretty good. 0.67 hazard ratio. So are you okay with that? Happy with that?
Yeah, I'm happy with that.
Okay. Dr. Bishwajit, your thoughts on the design, and would you think this is a good application that you use it only for the endocrine resistant?
Yeah, I think this is one of the bad population of disease. One, it is PIK3CA mutation, plus you have an endocrine resistant. And in that situation, we are able to show an OS benefit. So the drug is definitely working. My only concern is with the tolerability, as we already discussed about the tolerability.
Okay.
So I would use it if the side effects are tolerable, if it is better than alpelisib.
Okay. So Dr. Nitin, your thoughts on this sort of a triplet combination, because this is actually one of the first trials shown triplet and it has shown the overall survival advantage.
Yeah. So very interesting. And as we know, PIK3CA has sort of a little bit of mixed prognostic markers depending on the setting. In practice, those with sort of a PIK3 mutation, I mean, retrospectively, we come to know that they are not doing that well as compared to those who have not in a metastatic hormone positive setting. So given that, and that ultimately we would have to end up using it in the second line, I would say that the OS benefit this trial is showing, as long as if from a real world experience we begin to gather that it is well manageable side effect, I think we should use it.
Okay, excellent. So I think that's the take home message from everybody, that it seems to be a drug which is looking like it has its place to be used. Excellent. So my more random question, how many of us are very happy with palbociclib in this setting? Now tomorrow, can I interchange it with another CDK inhibitor? Dr. Bishwajit, in practice, a lot of us, for patients who can tolerate, we prefer using ribo or abema. Would you add ribo or abema instead of palbo? Or would you say trial says I will give only inavolisib, so I use only with palbociclib?
The interaction between the other two drugs with this, I don't know if there is some data in the phase 2 and phase 1. Because with each of the CDK inhibitors, we need to recalculate the dosing, which in most of the phase 3 trials currently, whenever they're interchanging and using. So unless that data is available, I'm not very confident of using in terms of side effects.
Okay. So Dr. Soumya, what your thoughts? Because see, we are going to get somebody asking us this question, that we'll import the drug from abroad, because remember the drug is approved. So somebody wants to import it and use it in this setting, the rare one-off patients. would you be happy using it with palbociclib alone, or would you want to combine with a different one?
Yeah, I think that question is very valid, but this was discussed as a limitation of the study in the ASCO conference. So they told that the limitation is that we are using only palbociclib and not the others, and they are conducting right now a Morpheus pan-breast study to look into the interactions of this particular evanescence with the other CDK4/6 inhibitor. So that Morpheus study will answer the interactions part.
Okay. So, Dr. Nitin, can I be more controversial and see? The Sonia says that it really doesn't matter if you use it, and frankly, Palbo does have a good PFS. So, are you okay with using either Palbo, or you would also say, like Dr. Sonia saying that maybe I use the other CDK?
No, I think, to be very frank, sir, from our real world experience, Palbo has shown actually quite good results. So, and based on our own center and sort of multi-center study that we have done, Palbo has shown a very good PFS, and our OS data is also good. So I'm okay with using Palbo.
Perfect. Dr. KP, we talked about alpelisib, we talked about hyperglycemia. The inclusion criteria is pretty strict in this study. Again, in practice, we know that alpelisib in bad diabetes, and India has a pretty big bunch of bad diabetics. So would you stick very religiously to this HbA1c less than 6 and then only give it, or would you be a bit relaxed about it? Or let me put it the other way. If you have alpelisib, we want to start. What is your cutoff of the HbA1c or the sugars?
So with alpelisib, I'm a little more liberal. But if somebody is going to get this drug at present, I would not move away from the trial.
Okay. Okay. So at this point, but alpelisib, you're okay to be a bit liberal. But alpelisib hyperglycemia has been there. We have all seen it.
Agreed. Yeah.
So you're okay with alpelisib? Okay, great. So I think that was my major concerns with this. Toxicity is something that we have addressed before. Now, the reason why I bring this is in this inavolisib trial, there's a grade 3 or 4, 85% toxicity, but most of it is actually neutropenia, which is because of the palbo. The thrombocytopenia is less. The stomatitis grade 3, 4 is only 5.6%, though grade 1 and 2 is, any grade is around 50%. The hyperglycemia is there still in 58.6%. It is not that simple. And diarrhea at 48% with 3.7% of grade 3 and grade 4 is not very simple. So I think, Dr. Vishwajit, you made this point that inavolisib may have its own toxicity. So we really need to look at the toxicity. So looking at these numbers, what do you feel? Is it dangerous, or you think it's still okay to go ahead and try?
With this side effect profile, I would not go ahead. I think we need to really choose patients and then
fitter patients, younger patients, like I think Dr. Soumya was saying, or Dr. KP was saying, maybe restricted to fitter patients. Yeah, Dr. KP, your thoughts? Toxicity not that simple.
Yeah, I think we don't know, because unless we start using this drug, we will have no idea. So if you are using this drug upfront now, I think I would use it for a very good patient. And obviously, if they are going to import it, I would definitely stick to the criteria.
Okay.
Vamsi, can I come in?
Please.
If you look into the grade 3-4, we are looking at all grades. All grades could be very deceptive. The grade 3-4 that really one CDK4/6, which I'll be a little skeptical, put in the chat, is the Abima, because diarrhea is 50% all grade, but 4% is still a grade 3-4. And Abima is a very dirty drug for diarrhea. So I'm little skeptical to interchange with Abima at this point. Other than that, if you look at grade 3-4, you don't see much of a difference except for slightly thrombocytopenia. You don't see much of a difference for anything actually. So I think the toxicity and if I look into, if remember this trial, 6% only had to withhold and discontinue the drug due to toxicity. So it's not as toxic as alpelisib as we have seen.
Agreed. That's in fact what the ASCO discussion was, that it is not that bad and the toxicity seems to be less than alpelisib. But again, we have to start using this drug. Again, as usually in all happens in all best of ASCO, we end up discussing drugs that sound nice, but then we don't know how it is. So again, since in practice, what exactly can we do? So I just asked my panelists, Dr. Vishwajit or Dr. KP, you can take this. What would be your thought on, say, using alpelisib plus a CDK4? Because, ultimately it's a PIK3. Alpelisib is not easy to handle. We don't have a trial of alpelisib plus a CDK, but this gives you the idea that a triplet might work better. Any thoughts, or anybody would want to do that for the patient? Dr. KP, you can take that.
No, I would not do it at present.
Okay. Dr. Vishwajit? No. Okay.
No, I don't think so.
You don't think so. So you would either give inavolisib or you will not give anything. Fair enough. Nitin, same as you?
Yeah, absolutely.
Very good. So I think south of the Vindhyas, we are a little bit more conservative when it comes to mix and match approaches. So fair enough. Somebody wanted to know about the OFS. Dr. Bishwajit was talking. I think I'll not take that question here. That was discussed quite well by Dr. Randeep yesterday. So the next question, ESR1 mutations, are we routinely testing? And everybody has said, yes, we would test it. Now we've started to test it. So I think Dr. KP, you said you would test ESR1. What would you do if ESR1 comes positive today?
So if it comes positive, I would use fulvestrant as of now.
Okay, but that's if you're at baseline. Supposing patient is already on an AI, that's an endocrine resistance or an endocrine sensitive relapse. What would you do if ESR comes positive? Because ESR1 comes positive mostly on exposure to the drug. So what would you do after that?
Yeah, so if somebody has been on AI and obviously when we test ESR1 is positive, I would offer them elacestrant, but most of the time it will be fulvestrant which will be given.
Fulvestrant will be given, and the responses are not great.
Not great, agreed.
Not great. So, Dr. Nitin, how do you manage?
Yeah, I mean, based on the recent data, you would offer elacestrant, but right now we would use. So if you're saying that they have progressed on CDK4/6 plus AI or only progression on AI?
We'll take it as progression on CDK4/6. I think standard approach now for everybody is giving CDK4/6 in first line. Let's not change that.
Right. So this is where sometimes possibly I'm being a little controversial here, depending on whether it's oligometastatic progression or not.
Oligometastatic, leave it. That leave oligometastatic. We will treat it as
I am tempted to change the CDK4/6 partner and add fulvestrant.
You would do post CDK like a post monarch or a
right
choice.
Right, so possibly like the right choice. So from Palbo move to Abima or Ribo and add the fulvestrant.
That's one of my questions. Would you prefer doing that or would you prefer using the thirds? That was what I was asking. So you said elacestrant. Very good.
Right.
Dr. KP?
Yeah, I was about to tell that I would probably continue CDK4 inhibitor and not stop it and add fulvestrant, even though we know that the results are not that great.
Agreed. Dr. Bishwajit?
Yeah, I would also continue the CDK and change the partner hormone therapy to fulvestrant because oral SERMs are very expensive. And
oral SERMs, exactly. Dr. Soumya?
Yeah, so I think the oral SERMs is the only, this is the only area where the oral SERMs has proven its efficacy. So if it is available, and then probably I'll change to oral.
Very good. So can I be a little rude and ask Dr. Nitin, see, I'm assuming I'm a patient who comes and you say, yeah, we'll give you elacestrant. What is the benefit with elacestrant in this setting, ESR1 positive? What is the PFS advantage with elacestrant?
Right. So that is why I said that I would offer more. I would actually push the patient more towards a CDK4/6 and fulvestrant.
Okay, fine. So I'll show you that data because frankly, the whole third hype, at least just with elacestrant, doesn't seem to be so great. But this was a very interesting paper. The initial paper, they looked at whether PIK3 and ESR1 mutations are there. What is the benefit for using abemaciclib? And what they actually showed is that if it is a PIK3 mutant, still abema seems to work. And if it is a ESR1 wild type, ESR1 mutant, still abema plus fulvestrant does seem to work reasonably well as well. So it's not that if you have an ESR1 and this, you cannot use a CDK4/6. So like all my panelists are saying that you would like to continue CDK4/6, it's not wrong to do that. Again, this is not a trial designed to look for it, but it just gives you an indication. So this was the very interesting paper. This was actually a plenary that came this time about camizestrant. Camizestrant is another SERD. There are plenty of SERDs. So this looked at doing a ctDNA testing. Again, this paper initially has come along with the ASCO. So this NEJM paper has come. And what they looked at is this was the Serena-6. They would do a testing for a patient who is on AI plus CDK4, and then they would change the SERD to full camizestrant if the ctDNA showed a positive ESR. Okay, so only ctDNA, no liquid biopsy. Every 3 months, they would do a testing. Practically not easy for all of us. We are attuned to doing it only at progression clinically. Here, they did not look at clinical progression. They only did it when patient had a ctDNA positive. At least 6 months of CDK4/6 should have been taken. Now, in this, they found that in the first test, 53.5% got positivity, 46 got it at subsequent tests. And now the interesting part is patient had one mutation in 83%, multiple mutations 16%. These were the common mutations. The time from initiation until randomization is almost 23 months on a median. So that's the other thing. So 23 months patient had already taken the drug and then they got a ESR1 mutation positive. That's the average. That's how it looked. This is the flow. So they actually screened 3,300 patients. Every 2 to 3 months they did a testing. Okay, I don't know how many of our patients can do this, frankly, because they were using Garden 360 CDX and we all know the price of that. So every 3 months you do a testing for a patient starting at 6 months. And then if you find a ESR1 positive, so out of 3,256, they found 320%. So, they found 548. So it's only 1/6 or 1/5 who were positive. In that, whatever they found, they actually discontinued due to screen failure because of disease progression and other things. And only around 340 patients, 325 patients could be taken into the trial. So again, remember, it is not for everybody and you may or may not pick up for everybody. Now, the median interval, like I said, was 23 months. That's the median, not the mean or the average, but the median. So this was the endpoint. So what they did is if patient has a ctDNA progression, you change to camizestrant. Otherwise, just continue with your normal treatment and wait for clinical progression. And the difference is pretty significant, 16 versus 9.2 months. That's pretty significant. Look at the hazard ratio, 0.44. Extremely, extremely good numbers, I would say. Again, looking at the overall subset analysis seems to work everywhere. This was the initial time to deterioration in global health status. They have looked at a different thing every time. Every trial shows us a different thing to look for. And it also said that camizestrant does better. So, Dr. Vishwajit, your thoughts on the study?
Yeah.
Would you think that ctDNA, we are ready for prime time?
So this is almost similar to a phase 2 study of the palbociclib, which was the PADA study. So in that also they used a similar kind of thing that they gave. They did ESR1 mutation every 3 months, and whenever there was a radiological progression, they changed that to fulvestrant instead of camizestrant. So in that also they had shown a PFS benefit. Now this is a phase 3 trial.
Yes.
And this also again is showing a similar thing. So only question is whether we could just change even fulvestrant instead of camizestrant is we don't know. Even maybe fulvestrant also is possible. The only question is how often do we do the ctDNA and the cost aligned to it. It's a very interesting method of doing. If the cost and this comes down, probably it would be nice to do. But again, I'm not sure there is OS benefit. Again, that's just the PFS.
We don't know. OS benefit, we don't know.
We don't.
Dr. Soumya.
Yeah, so it's different from PIK3 alpha. PIK3 alpha, even in non-meta study, is 40%. But this one, ESR1, it develops with time. So upfront, it is only if we test
less than 1%.
Yeah, so it develops. So definitely, it is something like T790M. So it develops with more and more with time. So and we got the T790M even with the blood, and that is done at a cheaper. Yeah, so if a cheaper alternative is there, then definitely I will go for this.
Dr. KP plans on doing it. Some lab comes and says in India, okay, we'll do only ESR1 for 15,000 or 20,000. We won't do Garden 360 for whatever reason. We'll just do this one single test. Interested?
Yeah, I would not do it. See, progression-free survival benefit is absolutely, I think, not the way to go with this. Obviously, if you start treatment early for some patient, you will have a PFS benefit. I don't know how much of it is just a lead time bias.
Fantastic.
If there is an overall survival benefit, I don't think we should change.
This is a very good point you made, because the next slide, now this is what we are looking at the other search. Look at elacestrant. Now elacestrant made so much noise and everyone started thinking, oh, elacestrant we should do. Now elacestrant actually looked at all comers, and what it showed is the patients had used prior CDK. The standard of care was only ET. They did not use another targeted therapy, and despite that, the hazard ratio is 0.7. The benefit is only around 5 point some months versus 2 months. So it was like just a 1.8 month benefit, hardly a huge amount. Whereas when you looked at this study, when you started looking at the lead time, you gave camizestrant early, it becomes a nice 7-month difference. So again, like you said, whether this actually will reflect in the real life, whether we do it at radiological progression or ctDNA, I am not sure that it will show the same benefit. Dr. Nitin, do you agree with that? What's your thought on this?
Yes, I mean, it is sort of very tricky situation, but I would always say that for the benefit that elacestrant is giving, it's definitely not worth it, and that's where continuation of CDK4 and the fulvestrant, as we have seen in real world in our real practice, possibly offers a more cost-effective benefit.
No, I completely agree, because well, it's always interesting because there seems to be such a hype and a hope for doing ESR1. You know, every meeting we go to and everyone says, oh, we have to do ESR1. But then you have drugs which are not really that fantastic drugs. You know, these are not the CDKs. These are not what we see normally. You can always argue that incremental benefit is there, but then that's how it is.
The only place where I say that ESR1 is possibly has a role to do is, you know, a patient who relapses at that time point of 2 years and you don't know if they fall under that endocrine sensitivity or resistance, you know, that's the place where it has, because then you would upfront start with fulvestrant with CDK4.
Vamsi, 5 more minutes.
Thank you. So
just one thing, we all are speaking, but look at the PFS Kaplan-Meier for elacestrant, and you will find a very typical, which you'll never see, that dip happens and 50% nearly goes away in the first 2 months.
Correct. That's exactly what I was saying.
That's why the OS looks to me good enough, and then at the 1 year you have 10% more survival.
Okay, so you are okay with the initial dip and say that only?
No, I'm not okay with the initial dip. What I'm telling is the PFS is not the way to look at for this search.
Okay.
The look at the OS, and 1 year 10% more for hormone positive is not good, bad. I'm telling you.
Okay.
That's what
So 6 month OS and the 1 year OS is 82 versus 73. You feel it is good enough?
It's not. It's better.
Okay,
than
fair enough.
Achieved.
So this is vepdegestrant and it's a PROTAC estrogen inhibitor. So I think this is for Nitin, the quizmaster. What does PROTAC stand for?
So PROTAC is one of the.
What does it stand for? Full form?
Okay. No, I'll tell you. It is proteolysis targeting chimeras. I was trying to get the
answer was out.
Just the thing. This is difficult for us. I mean, I remember 6 months back I put a paper saying PROTAC and nobody, and it is in the future, and already we have a study this year. I have just put it because it's a vepdegestrant PROTAC inhibitor. This is a new drug. Again, I don't think we're going to get access to this for plenty of years. But interesting drug again, they also looked at fulvestrant versus vepdegestrant, and a very similar trial where they looked at patients who had ET earlier with CDK and was a progressed, and then you look at ESR1, and then you do this, and the baseline characteristics, they have both the groups, almost 50% had the ESR1. And here again, when they looked at the PFS, this is same thing what Dr. Sahu has been saying. Every trial of the SERDs, your PFS for up till 40% of patients is bang normal. There's a dip, and then the dip starts separating slowly, and whether that translates into an overall survival benefit, it is not in every patient, only for the ESR1. For some places, we are seeing that overall survival benefit. So it's not as easy to say, oh, ESR1, let's give a SERD. I think we are still looking at the right SERD. We don't know that yet. In that conclusion, we had the EMBER study, which looked at imlunestrant, which is also one more SERD. But imlunestrant did an interesting thing that they combined it with Ebima, even though patients had received CDK earlier. And again, it did show a pretty good response with very reasonable HR. So, you know, imlunestrant seems to be, for me, one of the better drugs, especially if you combine it with Ebima. And I think that's the way ahead. A single SERD alone doesn't seem to work, doesn't seem to cut the ice. So let's start off with a quick fire rounds. Dr. Soumya, right SERD for ESR1. You get an ESR1, what do you do? This is not in India. This is all the options. Which would you select?
Yeah, probably the CAMI one.
CAMI. Okay, you are more convinced with the CAMI data, so you're not convinced about the lead time bias. You only told me about the lead time bias.
No, but the graphs separate early compared to elacestrant and the vepdegestrant.
Okay. Dr. KP?
I need to read more.
Okay. Dr. Nitin?
I would go with the imlunestrant with the abemaciclib.
Imluno plus Abema.
Yeah, because so the other thing about that trial, I mean, when we read it properly, is they've looked at the restricted mean survival, and that was almost close to 1.5 years versus 6 months, 7 months, something like that. So when I read up that paper, that is what sort of really stood out.
Okay, very good. I haven't read in that much detail. Like Dr. KP said, I have to read more in that. What about the right PIK3 inhibitor? You have a PIK3 positive. Will you give everolimus plus ET? Will you give alpelisib? And if you have a choice, inavolisib. Dr. Soumya.
It's a tough one because I haven't used alpelisib and inavolisib. I'm worried about the side effect part. But look, if it is similar to what the trial results are, inavolisib plus palbo.
Okay. Perfect. I think that's what most of us do. What about the AKT3? Dr. Nitin? Dr. Bishwajit, sorry, I have not asked you this. Dr. Bishwajit, AKT3 comes positive, capivasertib or anything else?
Yeah, there's only one drug. So
Capivasertib. Fantastic. So these are the treatment line options. I think this is by and large what everyone says. But again, I want to bring across the point. When you talk of multiple drugs, it sounds like you have great options. But honestly, the continuation of CDK beyond
Sorry to
progression
interrupt,
seems
sir. Only 5 minutes to go.
5 minutes.
Conclude your
I have
panel
5 minutes
discussion.
left. I
3
thought only
minutes.
1 minute.
3 minutes.
2 minutes. Yeah, 2 minutes. I'll finish. Don't worry. So it is interesting that the SERDs don't give you that huge PFS that we would really be looking for. And the kind of jump we got when we added CDK4/6 to a AI from 10-month PFS to 24-month PFS. After that, we are really not seeing that kind of huge jumps. We're seeing incremental benefits of a couple of months, but that big jump we are still not seeing. That's my take on this. Atmanirbhar Bharat, what do you do? Because none of what I talk today is available in India as of now. So Dr. Bishwajit, quickly, endocrine naive patient, first line. What would you do?
endocrine naive CDK inhibitor plus
Excellent. Endocrine resistant?
endocrine resistant, also the same currently.
Okay. So endocrine, you will use fulvestrant plus CDK4.
Plus fulvestrant, yeah.
Plus fulvestrant. Endocrine sensitive?
Endocrine sensitive with the CDK inhibitor plus.
Say CDK4 plus fulvestrant. Wonderful. Dr. Somya, same three things for you?
Yeah, same 3.
Same, no change. Perfect. Dr. Nitin, anything different?
Yeah, I mean, endocrine sensitive, we would use still AI with CDK4/6, not fulvestrant.
Okay, fair enough. AI plus this thing or that. Very good. So, important question, what do you do if patient has used adjuvant CDK4/6 and comes to you after 3? This is going to happen because we have been starting to use adjuvant CDK for the last couple of years. So, you are going to get these patients. Dr. KP, what do you do in that situation? What will become your first line? Would you re-challenge with a CDK4/6?
Yeah, it depends on when the patient comes to us. If the progression-free survival is quite long, then I think I would use it.
Define quite long, 2 months, 2 years, 1 year, 6 months. What's your definition?
The longer, the better.
Okay, hard to pin you down, Dr. KP. Great. So I think that was all the things that I wanted to discuss because these all are what we are going to talk about. I think the Protax is something that is interesting because a different mechanism of action. Ivanasulib is having a different mechanism of action. How many of these we are going to get to use in the next 1 year? I don't know. But
The Protax thing, I mean, it was interesting because this is the only other cancer apart from myeloma where the proteasome and the ubiquitin pathway is being used. So
good. That's something which I had not thought of, but you're right. That's an interesting point that you have brought out. So Protax are being actually used in multiple other cancers. I think we are going to start getting results soon. This is because there's a ER nuclear receptor. That's the reason it is probably being done. So we'll start seeing that in other time. So anything else from any of the panelists, or I will close?
Anyone in the panel wants to speak something?
Yeah, think about everolimus.
Yeah.
Bechara everolimus.
Go ahead.
No, I told Bechara everolimus. No one spoke.
Bechara everolimus. I still use everolimus, by the way. It is not that, I mean, you can use it. Probably 5 milligram alternate day is what we use. So I think that's about it. As Dr. KP says very nicely, I think I'm going to read out this comment. You need to be a nerd to remember all the CERT. That's an excellent closing statement. So thank you, Dr. KP, for that, and good night.
So there are two things. There is a question in the chat, and actually I wanted to get the answer. Vishwajit started it, and few of the panelists supported it. One was Vishwajit, you spoke about in the metastatic setting, and there's a question answer which needs to be we need to answer that. Do we think that OFS in addition to TAM is better than TAM in a metastatic setting?
I'm sorry, I didn't get the question, Dr.
Vishwajit,
I think your question is that in metastatic setting, whether OFS plus TAM versus only TAM. Is that
only
right?
TAM. Do you think there is superiority of adding?
No, I don't think there is an overall survival benefit. There is in a metastatic setting only there is a progression-free survival. But his question was in the adjuvant setting. I think it was in a different.
Yeah, it was an adjuvant setting. It was an adjuvant.
So I think that confusion was needed to clarify.
No, that we sorted out. It's only an adjuvant. I was saying that if you have.
But in metastatic setting, it's only there is some PFS benefit, but there is no OS benefit.
Okay,
the
so
reason
I
put it there is because I wanted to ask how many people actually still use tamoxifen alone.
That's fine. So I needed a clarification because student had asked it. That's more important.
Sure.
So the second thing, Amish had put up his hand. Amish, you wanted to say something on what was discussed in hormone positive? You can just come in.
Thank Vamshi. As always, excellent. I learned a lot. My question was, you are doing the first abstract. Dr. KP said that he will be skeptical and will use this oral SERT only, this PIK3 inhibitor only in young patients.
Younger and fitter
ऑप्शन
patients.
क्या है हमारे पास? हाँ, ऑप्शन क्या है? मतलब we all know that these are the endocrine refractory patients and that also in adjuvant setting less than 12 months. AI plus CDK नहीं काम करने वाला है. So something extra needs to be done in these patients, and that is what KP said. Chemo, yes, we should look at chemo for these patients. But my point is that even if not young patients, even if not fitter patients, and I don't agree with Tarini that when you're not left with much choice, Abima, what will it add? It will add you now we all know how to treat diarrhea because of abemaciclib. Inavolisib will add 4 more percent, not more than that. That is how I look at this data.
Okay.
So you feel that with the amount of problems we have in Abima, at least I see a lot of toxicity in the first 3 months and 4 months. It's a difficult drug to handle. You would be comfortable with that additional, because it won't be 4% just. It will be a add-on. 1+1 would not be 2. That's my feeling. It will be 1+1 would be 4 here. So that was what I
No,
thought.
the
That one
question,
CDK.
your point was, Tarini, not that.
Yeah. So my point was
One
that
CDK I do not change with another CDK.
no,
One
no, no,
CDK
no,
I
no.
do not replace
I
with
answer the
another
question
CDK.
of when Vamsi told, would you replace the triplet therapy which he asked with any of that, because the trial was with Palbo. I just told that with that I will be very skeptical with
Correct.
the drug, the Innovo trial. I would be not doing Abima. That's what I meant actually.
Okay. I think Dr. Amol has a question and Dr.
I
Prabhat.
agree.
Yeah.
Amol, last word and then we move
Yeah,
on.
please go ahead. Sorry.
Am I audible? I hope I'm audible.
Yeah, you
Yeah,
are always
you are
audible.
audible.
You're always audible on the internet and off the internet.
So my point here is this, that we have recently reviewed for an IGMP article about all these studies, and what we have realized is that only time when we can follow a CDK inhibitor by another CDK inhibitor when the previous CDK inhibitor is palbociclib and you are ready to follow with abemaciclib. Otherwise, it is of not much use. That's the first thing. Am I still audible?
Yeah, we are still hearing you.
Hello?
Yeah, we can hear you.
Yeah. And so if we have used Palbo before, then there is a point in adding Abima later. Otherwise, there is no other CDK inhibitor after CDK inhibitor. Second point is that we all comment about those curves falling in first 6 months, and this was discussed in ASCO also. And what was thought of that, there may be certain endocrine resistant mechanisms beyond ESR1, which we don't know as of now. And probably these are the patients where endocrine therapy is never going to work, and we probably have to think that introduction of chemotherapy to them. And we don't know the biomarkers as of now to decide which are those endocrine resistant patients beyond ESR1 where probably early introduction of chemo is going to help.
Okay.
So that's what my two
point
points.
taken, Dr. Amol. I think that's what everyone felt, and chemotherapy was a part of the chat discussion. And but if you don't give that SERD, you will never know who are progressing fast. I think SERD has a place. Yes, we need better SERDs, and the time is going to come where the things will be
You
better.
need better biomarkers.
Yeah, we need better biomarkers and better drugs also.
Yeah.
So with
Hey,
that,
Dr. Sahu, Prabhat is there, just raised his hand.
Yeah, Prabhat,
Last
last quick 30 seconds.
Sir, if we, I am not impressed with 7 months of survival benefit of evanelisib. What will my panelist comment upon celecoxib? We know from colon that it works in PIK3CA inhibitor patients. Simple, available, no other available drug which is so easily tolerable. Just from our precision oncologist, any comment?
I will give a simple answer. I will wait
Okay.
for the TMH data to come out. I'm sure you guys are already doing a study in it, so I'll wait for your data. That's the answer.
No, but Prabhat is right. If you open the NCCN guidelines for colon cancer, even if you give chemo or not chemo in adjuvant setting, but if there is a PIK3CA mutation, then you give aspirin for 3 years. And they have put that as the only option. They have not given any other option. So I think
So
it's
that
a very interesting thought process.
that entire paper can be a part of an OBTO discussion, whether that recommendation and that paper is a worthwhile to pursue. So maybe some other time
Okay,
we'll discuss that paper
I'll
again.
just intervene some other day, some other deep dive. We'll do it. We need to move on. But the point, only thing is, Prabhat, thing of 7 months is something we need to see the curves. We need to discuss these curves better before we really come into. But yes, hormone therapy, breast cancer is again going to get more complex with the options there. So we'll move on to the next one. And I think the blockbuster trial is with Amish. He twisted my arm to take this moderation actually. So I was joking. I was joking.
Conflict of
Tarini, you are going
interest.
to be my fourth
Conflict of interest.
panelist.
And yeah, okay. Even Amol is there. Everyone is
Yeah,
here.
Amol is
Oh,
there,
yeah.
but Tarini, you are good because Dr. Seema
Okay.
can't join, so you are going to be my fourth
Okay, I'm
moderator.
there. So we will have the HER2 positive metastatic breast cancer. So Dr. Amish will be moderating. Please may introduce your panel.
So I have my screen is visible.
Yes.
My slides are visible.
Yeah.
Okay. So I have four panelists: Dr. Ashish Singh, Dr. Bala Stalin Chaudhary, Dr. Amol Akhade, and Dr. Tarini Sahu.
Yes. So we are
Okay.
starting at 7:48. We'll continue till 8:25.
No problem. Tell me, Tarini, whenever you want me to stop, I'll stop.
No issues. No issues. Yeah, let's continue.
Okay, perfect. So, we are going to discuss three trials today, three abstract trials, presentation, whatever you call. It's a Destiny Breast 09. Second is Patina, and third is Detect V trial. Now, I'm going to Detect V because I have not given my panelists this topic, which I later. But Tarini, you are right. I searched and searched and searched, but every media article is full of only Destiny Breast 09 and nothing else. So, we are including that one of the topic. All the three abstracts or the presentations, what we are going to discuss are going to be in the first line treatment of HER2 positive metastatic breast cancer. It can be either hormone positive or hormone negative.
Hello. We lost Dr. Amish.
Yeah, this Zoom is a very notorious thing. I'm
Hello?
never comfortable with it.
Which one? Amol, you are saying something?
Yeah,
not
I'm
happy
not.
with
I'm never
Zoom.
comfortable with the Zooms. Yeah, it
No,
always
but
goes off and on between.
yeah. तो ट्विटर में इसको उठा यार.
No. That is beyond my domain in X. We only talk about oncology on X.
Tarun, can you just
Occasional
connect with
politics.
Amish?
So
I think
when break
Amish must have got a phone from AZ. Amish must have got a phone from AZ.
Your bandwidth is low, so you switch off your video. So your voice will come more clear.
Okay.
Yeah, Amish is back.
Yeah, I'm back.
Yeah.
And Amish,
got
you
the
had a
message.
call from AZ. That's what Amol was saying.
Yes. I thought that. Wild guess.
I had a call from AZ telling me what?
How to...
We don't know. How do you know? We don't know.
Okay. Is my screen visible?
Yeah, it is visible.
Okay, perfect. So let me start straight away. That the first question which I wanted to ask, and Dr. Ashish is visible on my screen. Let's take triple positive metastatic breast cancer. First line treatment is what we are going to discuss about. And this is the NCCN guideline, which was there last year also and this year also, where they do not say whichever is category 1 recommendation. What they say, you can use systemic therapy plus HER2 directed or endocrine therapy plus HER2 directed. So Ashish, in practice, very quickly, what percentage of your patients, if even if they are fit, you give chemo or THP versus AI plus HP?
Sure, sir. So I would say I hardly use AI plus HP unless the lady is so frail that I would want to avoid chemotherapy for whatever reason. And I think it's just because the volume of data is, especially when you're targeting the HER2 pathway in metastatic breast cancer, is mostly with chemotherapy. I know there are
Okay.
there are one or two trials, but also when the patient is going to spend so much on, say, pertuzumab and trastuzumab, I probably want to give her the best outcomes with that, and therefore I've always used taxane or chemotherapy.
Okay. Dr. Stalin?
Yes, sir. Majority of the times it is chemotherapy. A brief initial 4 cycles of chemotherapy with dual HER2, followed by maintenance.
Followed by maintenance. Okay, so Cleopatra way.
Yes, sir.
Perfect. Amol?
Same. No AI plus anti-HER2 as of now.
Okay, so Tarini, unless until you have some different answer,
No.
I would like to ask Amol. Amol, why have they put these two options like this? They should have put systemic therapy or the chemotherapy plus HP as category 1, isn't it?
Most of the time, NCCN is ambiguous, so I'm not surprised.
You're not
So
surprised. Okay.
actually, this has come. If there would be not much of a plus HER2 targeted therapy when they're telling of. This has come actually from 2 trials and 2 randomized trials where the primary endpoint of the PFS was achieved, but they did not have a OS benefit, which was one of the trial which I spoke actually in this OBTO, Amish, if you remember. So that NCCN puts in any data
Pertain
which
trial,
has a
you are
level
talking
1.
of Pertain trial?
Yes. So NCCN puts up any data which has a level 1 evidence. That's the thing.
Okay, right. So Pertain trial basically was comparing addition of pertuzumab. It was not comparing
No, not
endocrine
pertuzumab.
versus
This is
chemotherapy.
no. I'm speaking of 2009 trial. There's a trastuzumab plus anastrozole versus.
Yes, you had told in OBTO that.
Yes.
Correct.
So that is the reason why NCCN still puts.
Okay. So everybody has answered this question. So I'm going to go forward. You know, NCCN, as we said, still gives an option of AI plus anti-HER2 in these patients. As of today, we have TDXD as category 1 preferred in the second line treatment of HER2 positive metastatic breast cancer. And that's where we come to our first thing. And we all know that Cleopatra has shown overall survival advantage. This is something which we all have seen 7-year study also, which is there. Only thing, Amol, since you are there, you said that majority of the patients you will give chemotherapy with HP. In non-visceral metastasis, if you see this is a forest plot chart of Cleopatra, would you still use chemo plus HP?
The subset analysis is very difficult to have meaning out of it. I will still go for chemo.
We are not going to discuss about forest plot. What I'm saying is that 178 patients had non-visceral metastasis, hazard ratio of 1.11. You would still use chemo plus HP in non-visceral also, right?
Yes.
Okay. Dr. Ashish?
Yeah. So basically, I think so. Sorry, I missed it. Which trial is this? What are the two groups here?
This is Cleopatra
Okay.
trial, where they have done the subset analysis where non-visceral metastasis did not benefit by chemo plus HP.
But the Cleopatra, the control, they were just studying pertuzumab, right? So
No, that was Pertain study. Anyway, the point is that there is a forest plot. In your practice, if the patient has non-visceral metastasis and HER2 positive, you still give chemo plus HP?
yes, sir. So you're asking ER also positive. So then
Yes.
So then in this situation, so it's about trying to predict the biology. This is one situation where, if we discuss to delay chemotherapy, I think patients will be happy. And if it's only a few skeletal mets, maybe we can do that. But I would not be using pertuzumab here. I'll only be using
Can you
trastuzumab.
go back, Amish boss, for that forest plot? I think we need to clarify that. So I think this is the Cleopatra survival forest plot, if I'm not wrong. Okay, this is the Cleopatra forest plot for survival analysis. Okay, so the only thing that reads out and the p-value of interaction is significant is that in a more forgiving disease without visceral where there's a bony mets, and most of these Cleopatra majority quite a bit were hormone positive, you could get away without doing a dual HER2 because your survival will not be. If this is a survival thing, I mean it's not a progressive survival thing. It's a OS forest plot. Am I right, Amish boss?
Yes, absolutely.
So that is why you are getting this interaction.
That is the point.
Yeah.
That is the point. It is not dual anti-HER2. You can go ahead with chemo plus single anti-HER2.
Yeah. So I was coming to that. So it's in a lesser low disease, especially non-visceral bony thing, you still could get away and just get a benefit in the later lines. That's what it is.
Okay, perfect. Point well taken. That is exactly what I wanted to highlight, that we don't jump at a dual in every patient. We have to look at the patient. So coming to our first paper today, Destiny Breast 09. This is Daiichi Sankyo and AstraZeneca. They have given me some of these slides. So basically, it was a HER2 positive. I'll quickly run through the trial. Metastatic breast cancer, asymptomatic or inactive brain mets were allowed. DFI more than 6 months from the last chemo in neoadjuvant or adjuvant setting. One prior line of endocrine therapy for MBC was permitted. I think this is very interesting. And stratification factors, they have used PIK3CA, mutation detected versus non-detected. I think this is again interesting thing what they have added in stratification factor. Arm A, still the readout is not there. So we will discussing Arm B and Arm C. That is TDXD plus pertuzumab or THP. And you have to continue this trial, this drugs till progressive disease. Of course, you drop taxane after 4 to 6 cycles, but you continue with TDXD plus pertuzumab, and at the investigator's discretion, you can add AI or tamoxifen if it is HR positive. Okay. Now, your maturity was 38% in Arm B and Arm C, which I feel is a maturity which is there. Inclusion exclusion criteria, they have written that. This is something which the first slide which they have put, and the death is almost 4% in TDXT plus pertuzumab arm. Dr. Amol, before we go on to the efficacy, is 4% death acceptable? Dr. Tarini didn't accept 4% diarrhea to start a new drug. Is this, when you read any trial or any new drug?
Yeah.
Yes, Amol.
Yes.
Yes.
So 4% death, we need to see whether it is because of what is the reason of the death, whether related to the drug or not related to the drug. But yes, 4% death is something that needs to be looked into.
Okay, Dr. Stalin?
Yes, sir. 4% death rate is actually significant. If possibly every death in that is related to the drug, we need to be very cautious.
You do not have that data, Dr. Stalin, but if you see on the other side, other column,
wait for that data.
On the other column, 1 minute, Amol. Even if you don't have that, you have dash versus 0.5 in THP arm. So that tells us that whatever may be the reason of death on a clinical trial needs to look at very judiciously. Tarini, does this deter you going forward?
This death for me, I will be very skeptical. 4% looks too much, especially when the other two arms, the discontinuation was not because of death. So that is the reason I'll be very, very skeptical. I will look at the data in totality. But yes, death 4% to me on this slide is significant.
Okay, perfect. And Tarini and all of you are right. All 4% are not because of the drug. According to investigator, it was 1.9%. Which is there. Now, PIK3CA mutation was detected in almost 30% of patients, which was again quite significant to me, which was their prior therapy. As I was talking and as all the panelists have said, Again, this is very interesting that only 5 patients in each arm had received prior endocrine therapy. So the current practice looks like that you give chemo, that is taxane plus HP, irrespective of whatever it is, because this trial also did not have first-line endocrine therapy to many patients. So this is the February 26 data cutoff was there, and this was presented in ASCO. So this was the uh, independent committee, which was delta was 13.8, but this is the crux where you have investigator assessment of 40.7 months versus 20 months. Now this delta of 20 months is something which is, unheard of. Again, Amol, isn't this practice changing straight away? Do we have Amol or we have lost him? Let me start with Dr. Stalin. Dr. Stalin, this curve or this graph, delta
Definitely
of
practice
20
changing, sir.
months.
Definitely. With this much of delta, we had seen very less often in the metastatic HER2 positive in any line. So possibly, so it may be practice changing, sir. This
Right.
amount of
Am I
difference in the
audible? Sorry.
this amount of progression-free survival difference is definitely worth considering.
Right. Ashish, before you go on to your conservative self, look at the control arm. You have 20 months, right? And in Cleopatra, also the control arm, that is the experimental arm in Cleopatra, is a control arm here. There it was 19 months, and this is 20 months. So it is consistent. The control arm has done consistent since last 10 to 15 years. And the same here. So would you believe this data that, many a times we say control arm ne acha nahi kiya, not did well, but here it has done exactly the same. And you have a 20 months of delta.
No, sir. So there is
Definitely we can believe, sir.
there's no
Okay.
there's no doubt that continuing and very active drug like TDXD non-stop will keep the disease control for a longer time. And even if you see the PFS curves, right when the docetaxel stops, the curves begin to separate. And so therefore, I mean, there is no doubt that you will probably get a longer PFS for more toxicity if you continue this drug non-stop.
Correct. Perfect. So we have 2 people who will change their practice after this. Amol.
So yes, it is a very good data, but there are 2 points. One is some of us, including me, probably was expecting something more than this, not just 40.7. We thought probably it will go much beyond that, 45, 46. So it is like up ki baar 400 par, it has happened to TDXD.
No, but Amol, isn't the 20% delta not enough to change the practice?
No, I'm coming to that. So if it is not 400 par, it's not 240, it is good enough from government. So yes, it is good enough data, but we would like to see the full publication. We good data.
This is exactly what I'm asking. Since Amol is not audible well, Tarini.
Amol, first you switch off your video, your bandwidth. Amol, please switch off your video. Just put on your mic. Okay.
Amish sir, while
Yes,
Dr.
Ashish.
comes back, I'll probably put the question this way. In our real life practice, once we stop the docetaxel, how many of us are actually tempted to say add a capecitabine or say add letrozole and continue in the control arm patients in our real world practice? In the trial, I'm sure that is not allowed.
I'll pitch in here, Ashish.
In trial also it was allowed.
I don't add in metastatic disease. That's for sure. For coming to this, what Dr. Amish has asked, yes, this delta is excellent. It's a very clear cut. It's a no-brainer actually. But I think the drug TDXD itself is a dirty drug. It is a toxic drug. And point is, in such a drug which is costly, which has its toxicities and which has lethal toxicities, I will definitely look at the mature OS data also along with this. Let's say,
Tarini,
yeah.
so Tarini, right now we have to answer that we do not have the OS data, which is
So
mature.
I was coming to that. With this data set, would I offer it to my patient tomorrow if it is approved in the country? Yes, I will. But I will still as a oncologist, wait for the data, and if OS is not significant, and I would also look at how many of the patients in the control in the control arm actually could receive TDXD on progression. These two data sets will
Perfect.
really
So
answer a
we
lot
are
of
coming
questions.
to we'll be coming to PFS2, Tarini.
Okay.
Tarini, this forest
No,
plot chart is
we have
visible in front of
crossover
you.
data.
Amol, I can't hear you well. Can you go and join back again?
Yeah, please, Amish.
Okay, can you hear me? We have a crossover data.
So, Amol, I'll come to you. Tarini, you can see this forest plot?
Yeah.
Okay. So, PIK3CA and all other parameters, what we were worried about, you look at the difference, one, and second is what is your estimate that OS will not be significant with delta of 20 months in PFS? Percentage.
I'll tell you. You asked me a question. I'll tell you what I think. So what I feel is, if you look at the way that TDXD has done in the front line, in the post-progressive disease in the metastatic HER2 positive, look at that hazards and the delta, and when that is put into the arm of the control, I have my serious doubts whether if nearly 70 or 80% of patients receive a TDXD on progression, I really doubt there'll be OS advantage. I'll put my foot forward and I can tell that.
Okay, perfect. So we have the PFS2 ka thing. The brain metastasis is something which I also wanted to highlight, that whether it is present or not present, and we all know that TDXD works quite well in the brain, and it is again works, although the inclusion criteria was that you have to have a stable brain metastasis for you need to be included. I was quite amazed at that brain metastasis. This is something. So, Tarini, again, 15% CR versus 8.5% CR. And this, we were talking about this in neoadjuvant setting in bladder for OBTO. But I'm asking you here, 15% CR.
See, boss,
Does
we have
that
seen
tell
the
you that
data.
sometimes we will, no, my question is very specific. Does it mean that sometimes we will be able to tell some patients at the end of 7 years or 8 years that you are cured?
So now I'll tell you what it is. I'll put it in a different perspective. If I have a brain mets on the front line, and I have a metastatic patient who may be asymptomatic, and I have to give a drug of choice even at this point, this would be the patient group I'll push for, because all of us know that TDHD has an excellent brain activity, and this is what is being reflected actually. So that will be my take. I understand what you're coming to, but yes, I'm very happy with the delta what you showed. But my concern and my things will be the OS, because the activity of post progression second line TDHD is excellent. So that is my thing. I think I'm getting you are getting me what I.
I'm getting your point, and I have a slide very quickly coming on the PFS2, and we will discuss about that.
Yes, so Dr. Amish, if I
yes, Dr. Ashish,
because you used the word cure, I know when TDXD and TDM1 had just come, there were a lot of editorials, and I'm also aware of a small phase 2 trial where in metastatic breast cancer, the authors or the group is actually sequencing these drugs one after the other without waiting for progression and seeing if we can actually cure some of these. And if you actually see on this graphic, I'm pretty impressed with the response rates are equal. The PAT-CR rate is maybe 7% better, but that's also because the number of cycles of this TDXD you have given is much more than just 6, right? So I'm just tempted to actually just imagine, what if you do THP and immediately afterwards switch to TDXD and do 6 TDXD? You may be able to get a CR in many more than
right.
what.
Dr. Ashish, you may be right on that point, because there's an added overall. My point was, if you read the end of study paper of Cleopatra, there were 15 patients on the HP arm who had not progressed at the end of 7 years also.
True.
Right from the word go. And
true, and also
authors asked at that
many
point
of these
of time
many
that
of these good PRs can actually be CRs, because on the trial it's very difficult to classify CRs properly for everybody.
Right, perfect. So let's look at now something different. And Dr. Stalin, We will start with you. The first thing what I said is that in this trial, uh, giving AI or tamoxifen was allowed if you thought so. So in Destiny Breast 09s, assuming you have a patient who can afford TDXT plus pertuzumab and his patient is triple positive, would you give AI in maintenance setting? Dr. Stalin, we have Dr.
Sir,
Stalin?
yes, sir. Yes, sir.
Ah.
Sir, if the trial has not used it, I don't add it.
No, they have given an option. You can use it if you want to.
Preferably, I will add, sir.
Preferably, you'll add. Dr. Amol, a very straightforward question. Would you add AI in DB09 if you are treating that patient?
Yes, yes, in the control arm, yes.
You will. Tarini?
In the control arm, after chemo is over, yes. With the
No, not in
TDXD,
control, in TDXT plus pertuzumab.
No. Because we have
No.
data from chemo with AI hormone, there is a lack of efficacy. I would still know that a TDXD has a chemo component. I will not.
Okay, perfect. Yes. Somebody was saying something?
So we will clarify that in the control arm we'll add, but not in the trial arm. That's what
Okay,
Dr. Chang
perfect.
said.
Okay, I got him. And I get it. And that is what I think other panelists also said. And that brings me to my second presentation, that is Patina for today. Patina trial, again, very quickly, I'll say, triple positive metastatic breast cancer. You give 6 to 8 cycles of chemo plus HP. If the patient has CR, PR, or stable disease, you give HP plus endocrine therapy, or you give HP plus endocrine therapy plus palbociclib. That is what this trial was about it. We will not go into the discussion of the control arm because we have discussed about that. There's a patient characteristics which were there. Prior anti-HER2 in the neoadjuvant or adjuvant setting, 72% of the patient had taken. Now, this is quite a significant number of patients. And this is my crux, and I will start with Tarini first, then go to Stalin, Dr. Stalin. Tarini, addition of palbociclib is 44.3 months versus 29.1 month. But hold on, that is not my question. My question to you is, you see the control arm, it is 29.1 months. And in Cleopatra, the experimental arm was 19 months. Does it mean, and Cleopatra did not allow hormone treatment. Does it mean that you just added hormone and you have added 10 more months to PFS?
I feel after docetaxel is over, most of us in practice do that. Ashish spoke that we add chemo, but most of us after dosi is over, we add a hormone in HR positive. And that is,
We all do that, Tarini. What I'm asking is Cleopatra did not allow.
So I think that definitely has added on to what we are seeing.
Definitely added on to what? Dr. Stalin, even after adding that 29 months, you still have such a huge delta that, your addition of palbociclib gives rise to 15 more months of PFS. Isn't this again a great data, Dr. Stalin?
Definitely a great data, sir.
Definitely a great data. Okay.
15 months difference in the front line, definitely need to be considered.
Dr. Ashish, do you see this delta as significant?
Yes, sir. Actually, I think if you see the curve is just flattening at around 50% mark. So that is why the difference is big. So in real life, we will not see such a big difference. But then again, it's 44 median is much better than the 20 median which we just discussed in the previous trial. So therefore, so after THP, if I am able to add a CDK4/6 in my, everybody won't be ER positive, but at least for patients who are ER positive, that's a great option to have.
So
can you go back?
First,
can you go back, Amish, with that thing?
Okay.
I wanted to put one more for that trial. Yeah.
Yes.
I think if you look at the patient at risk at 50%, it is only less than even 20% of the patients. So I would not be commenting on that part because a lot of censoring has happened on that. But I have a different point. My point was, if you look at what the CDK4/6 have done in first line metastatic and the delta they have added on, is exactly what you're getting here actually. What is being reflected is with the hormone, you're getting another 10 months. And with the hormone plus CDK, the delta of around 12 to 15 or to 18 months, you're getting here actually. So basically, it is only reflecting what we have seen in the first line metastatic hormone positive with CDK4/6 plus hormone. That exact delta is what is being reflected. That's what I might.
Completely point well taken, Tarini. Now, since you have spoken, Tarini, so help me understand. TDXT plus P is 40.7 months is the PFS, and you add palbociclib and you have a PFS of 44 months. I know, it was all comers versus responders, but there is a 89% is the disease control rate in any of these trials. Isn't rather than jumping onto TDXT plus pertuzumab, you start with Cleopatra. All the responders you give CDK4/6 inhibitors. I think you're just left out with 10 more % of patients. Why spend so much of toxicity, money, and quality of life to these patients?
I
Tarini.
already put up this apprehension in my initial statement. So I totally would look for the OS data, look at the crossover data set, and with the hormone positive, Patina has a very practice changing impact. That's my take.
Patina is more practice changing than Destiny
For that
Breast
subset of
09.
patients. For that subset of patients.
For that subset,
Especially,
okay.
and especially
Perfect. I
when
think
in this patient, TDXT will work later on. We all know that.
Perfect. I think, this is the point which the entire world also is speaking about. Yes, Professor Amol Akhade.
So my question is, if you are so much impressed by Patina's data with palbociclib and we agree that Abima is better than palbo, why not add Abima by extrapolating the data? Will anybody like to do that in their own practice?
No, so Amol, lately, last 3 to 4 years, we have seen that cross is not something which we are practicing. We stick to the data results or the trial results as far as possible. Unless until we are forced to change, then we change. Otherwise, I don't see any problem with palbociclib here in this particular patient.
You may get more PFS benefit if you add abemaciclib or maybe ribociclib.
That is conjecture, Amol, and
okay. So you will not do that. You will not.
I will not do that. I will not do that. So again, we discussed about this that it is there. This was the 18.7 months what I wanted to show. One of the biggest criticism of Patina was randomization was done only in responders. Ashish, if I don't use TDXT plus pertuzumab upfront, if the patient can afford, I am missing out on non-responders because Patina was only in responders. Assuming a fit patient who can afford anything under the sun and says, "Okay, Doctor Singh, I want the best chance." Would you go for Patina or would you go for Destiny Breast 09?
So I think I will definitely show the patient the response rates, and I don't think this even THP is a bad option. Destiny 09 is also a very good option. Patina, I'm not sure what the response rate is, but I'm sure that if you use it upfront, you will not get such great responses. So of course, any patient would want a regimen with a good response rate upfront, and then a maintenance which is not so toxic. So Patina definitely not in the beginning, but as a good maintenance option.
Good maintenance option. Okay. So, Dr. Stalin.
How many were PD in Destiny 09?
Sorry?
In the control arm, how many were progressive disease?
10 to 11%, I think. So 89% was the disease control rate.
So 10%.
Yeah. So, Dr. Stalin, affording patient, Destiny Breast 09 or Patina, and you would wait for second line TDXT. Tarin is fully convinced that kahe waste karna hai first line mein.
At this point, with the OS data still pending.
Till the OS data is there. Dr. Stalin.
At least I agree with Sahu sir. So I use the Patina followed by second line TDXT.
Okay, perfect. And we have Amol. Just answer this question: affording patient, fully fit patient, Destiny Breast 09 or Patina in a triple positive metastatic breast cancer?
And Destiny Breast 09.
Okay, excellent.
With BrainMed,
Amol and I, we were somewhere today. Amol and I, we were this. This is what I wanted to highlight.
We will err towards this.
Yes, Tarini, I will come to you. This is what I wanted to highlight in Cleopatra. The responders, there also the duration of response was 20 months in pertuzumab group. So we really don't know unless and until palbociclib was used upfront and not just in responders, which is there. And this is a PFS by stratification. And this is to answer your question, Dr. Ashish. Even in the maintenance, palbociclib kept adding on the overall response rate, which was again something amazing and surprising. Although OS data in Patina also is not something which is still mature, and we don't have Destiny Breast 09. Also, there is no OS which is mature. Okay, this is something where I want Amol to answer. If we can hear Amol. PFS2, as Tarini has been saying again and again that he would like to see how many of THP get TDXD. There's 36.5% mature data. So this is not something which is we have a mature curve as yet. What does this signify as far as Destiny Breast 09 and Patina concerned? What does PFS2 signify? And for students like me, Amol, very quickly, I have 3 to 4 more minutes before Tarini shuts me up.
Mishra, if you go back to your previous slide, Mishra, this slide. So if you see here, the only about 10 to 12% of patients got ADCs. This is
that is the point. That is the point. The crossover is only 10% in Destiny Breast 09, and that is a very poor number for any international trial, considering the second line approval was given 3-4 years back. So I don't think so. That is a good number. But overall, the curves are reasonably okay. They are well separating, even though there is an early part crossing over of the curves. So I'm unhappy, but I'm not very happy also.
PFS1, Ashish, the crossover does not matter, right? In OS, the crossover will matter. In OS, the crossover, yeah. So, PFS2, yes, it will matter, and it helps in
Ashish
sequencing.
wanted to say something, Amish.
Yes, Ashish.
No. I just wanted to make that point that if the crossover, not crossover, if the post-progression therapy is so not up to the mark, we will probably have a very biased results in terms of overall survival whenever it comes out. And second point, I'm wondering, I don't know, I'll ask this as a question to all the panelists. What do you all think is the contribution of pertuzumab if it's when added to TDXD? Do we actually need the pertuzumab?
We will have the
So
answers.
we don't have the data readout of arm A. Arm A का जब आशीष data readout होगा, then it will be very interesting.
A versus B.
A versus B. And that is exactly will answer your question that how much addition of pertuzumab is doing. And they are smart enough to say that. I will quickly in 1 minute read out the third abstract, which I felt is very interesting. Omission of chemotherapy and addition of CDK4/6 inhibitor, ribociclib, in HER2 positive, triple positive metastatic breast cancer. And this is the second interim efficacy analysis of phase 3 DETECT-V trial. This is a German trial. Entire German group has done this trial. And what they did was that 271 patients were randomized to receive dual anti-HER2 combined either with endocrine or chemotherapy and followed by maintenance endocrine. Every patient received maintenance endocrine, and upfront, instead of induction chemotherapy, they received AI. And after 124 patients were enrolled, they added ribociclib to endocrine therapy in both the arms. Please remember that. Okay. Now, the overall survival did not differ between chemo-free and chemotherapy containing, but if you see the median PFS was 19.1 versus 22.4 months, which was not statistically significant. OS, the hazard ratio was significant, especially when ribociclib was added. So this is more like a Patina trial to me, that you have given chemotherapy, then you have given endocrine therapy, and you have added ribociclib. So you have a data with palbociclib, you have a data with ribociclib. Any takers at this stage, Dr. Stalin, would you add ribociclib, or would you, based on this trial, would you give chemo-free treatment to many of your patients?
As of now, no, sir. Still, I consider a chemotherapy-based approach, the brief initial chemotherapy followed by.
Perfect. Point well taken. Dr. Ashish, yes or no? You're not-
This data gives us more confidence to kind of now avoid chemo in probably more patients. Yeah, suitable
Okay.
patients. Not in high volume patients, but in patients where you don't need a response or a great response. I think this is a good option.
Excellent. Dr. Tarini?
For patient with high bulk, high disease load, I will still go for chemo plus dual. But if there is a low disease load or a very oligo metastatic, then this is a very good option, because we have to also look at response rate, which are very good with chemo plus dual, and then go the patina route. So that's my
Excellent. I think, the Tarini, this trial gives me two confidences. One, you can use chemo-free regimen in a low volume or non-visceral patients. And second, now we have a data with Palbo and we have a data with Ribo, both.
Yeah.
So CDK4/6 addition in maintenance is given, and we should do it in all patients. And is my conclusion, you agree with, Tarini?
I think patina, we spoke about in OBTO, it is going to be a potential practice changing. And what is happening, we're pushing the CDK4/6 up, and the delta which I spoke, that is what is happening. And I think all of us will change practice, and all of us will add this.
Perfect. Amol, you say something before I give my concluding slide?
No, I agree that we can add CDK inhibitors, especially most of our patients will not be affording pertuzumab, so palbociclib will be a cheaper option to add.
Perfect. So my take on all these three papers, and then I will close my panel. TDXD plus pertuzumab, I believe this is an excellent PFS data, and delta of 20 months is something which we cannot deny our patients of today, if they can afford and if they are fit. I would not wait for OS data and deprive those patients today, when the OS data readout may be after 15 months to 20 months. And we have done the same thing with Natalia and abemaciclib, both in adjuvant breast setting. So I would say it is practice-changing PFS data. Palbociclib plus AI in maintenance after THP is again worth considering as practice-changing in all patients of triple-positive metastatic breast cancer once they have responded to THP. And chemotherapy-free treatment in triple-positive, I would restrict right now. Either they are not fit for chemo, or as Tarini says, in low-volume disease. With that, I close my panel, and I again thank Tarini for giving me this opportunity.
Oh, I have four questions. I want you to hang on and answer this for.
Okay.
First question is, would you like to give Ribo/Abema instead of Palbo in all these patients which you spoke of, although we don't have a trial? So I think Dr. Amish spoke about the Ribo trial in the last abstract, and that is the interpretation that we are getting the advantage of CDK4/6, right, Dr. Amish? So
absolutely agreed.
So one more question is there, if a triple positive breast cancer patient is on adjuvant letrozole and trastuzumab, adjuvant, okay, I see has recurrence on the 4th year. So I expect trastuzumab should have been completed by that time. So it is only letrozole. Again, the receptors are triple positive, Dr. Amish. Will we choose Cleopatra regimen in this case after 6 cycles, or would you add fulvestrant to the hormone HP maintenance?
No, so Cleopatra regimen is something which they have allowed, that if you have more than 1 year of DFI after completion
actually,
of
this
trastuzumab.
patient has progressed on 4th year of letrozole.
4th year of letrozole is secondary hormone resistant, not the primary hormone resistance.
Yes.
So you can continue. Yes.
So would you add fulvestrant to the HP maintenance, or if you believe in patina? That's what the question was.
Letrozole plus palbociclib would be my go-to in that patient after
Again, you
Cleopatra
re-challenge with letro plus palbo.
Yes.
Anyone in the Ashish or Amol or anyone wants to have a different answer on this? Sandil boss, you are there. I saw you. So in a secondary resistance with letrozole, Sandil boss, he's joined, but he's probably not there. Amol, what's your take on that? Patina, extrapolating patina for this progress on letrozole 4th year. Would you add any other hormone therapy, or would you add CDK4/6 plus letro again?
CDK4/6 plus letro again, because we don't have a data of fulvestrant plus CDK inhibitor in this particular setting.
Okay. So I think we'll ask again Sandil Vensi. He has the last lecture. So what is the best post-protocol therapy given in TDXD arm? Dr. Amish, we spoke of that. He showed the data set. I think that has been answered. Last question we'll skip. I am not really getting that what the person wanted to ask. I don't think. Did you show any slides, Dr. Amish, where the THP arm had a median OS of 20 months?
No, not median OS of 20 months. 20 months was the median PFS. That was
Yes.
in
So I think
2009.
I think the author of this question was confused with that. I think we answered all the questions. So we will thank Dr. Amish and the whole panel. And now we'll move on to the last panel before we go to the top 5 abstract picked by Dr. Sandil. So may I invite Dr. Krishna Prasad, a dear friend, has been a colleague for quite some time and an excellent moderator. I always have regarded him very high. And we have his panelists, Dr. Chetan, Dr. Suman, again from, thank you Suman for joining. Sefali, again, we had yesterday. Prabha, we always have a very practical approach, Prabha. So please, KP, next 35 minutes.
Thanks, Sahu, for this opportunity. And it's an honor for me to moderate these panelists, Dr. Chetan Deshmukh from Pune, Suman Karanth from Gurugram, Shefali from Delhi, and Prabhat from Mumbai. So, when Sahu gave me this topic, I actually emailed to him asking for help in selecting these abstracts, because I was under the impression there is absolutely nothing new in TNBC in the metastatic setting. And thanks to people like Amol, I was totally wrong. And I came to know that, in fact, Destiny has been beaten. In fact, Ascent 04 is the one which is maximally commented upon. 30,000 or 300,000 views. And you can see maximum number of people have put this as a practice-changing trial. So, and I looked at it, after the top 10 trials in May 2025, you can see 4 of them are in the metastatic TNBC. This came as a totally surprise to me. And I would like to highlight the first trial, the Ascent 04. Now, you look at Ascent 04, this is a phase 3 trial of first-line sacituzumab govitecan plus pembrolizumab versus chemotherapy plus pembrolizumab in PD-L1 positive advanced TNBC. I think out of 35 minutes, 5 minutes will go on in pronouncing this sacituzumab govitecan. We can either make it SG or we can make it Sunil Gavaskar, whichever you like. So the first point is 40% of patients with metastatic TNBC have PD-L1 CPS score more than 10%. So the question is, PD-L1 testing in practice, what percentage of your patients are you doing it? How are you doing it? And percentage which is positive, and how many percentage actually gets acted upon? Chetan, let's start with you. PD-L1 testing in MBC, TNBC. Chetan, are you there? Dr. South? Chetan
He's logged in. I don't know, but he was not there. You can ask the others.
Okay, let's go to Dr.
Yeah, I am there.
Oh, yes, Chetan.
Yeah. So, in triple negative metastatic setting, there is always some time when you need an additional option. So we end up doing PD-L1 testing for almost all our patients with metastatic disease at some point of time.
Okay. And what percentage of them have you acted upon, and which test are you doing?
Sorry?
What is the percentage of patients who are positive, and what percentage of them you have actually acted upon this PD-L1
Yeah.
positive?
So percentage for metastatic disease, since the cutoff is more than 10, that number is not very high. We end up having probably about 15 to 20% patients. And of these, if I do it for 100 people, 20 come positive, I end up giving immunotherapy for maybe 3 or 4.
Okay. Prabhat, in TMH, are you doing it for all, and which test are you doing it, and percentage positive, and how many of them actually get treated?
Sir, I agree with Dr. Chetan. We are also not doing with everyone for everyone, and hardly any. I counsel patient only if they are going to afford and immunotherapy, then only I do it. So roughly 10-20% only patients I do it. And after that also positivity is something of more than 10% is hardly found. So I act finally upon less than 5% of patients.
Fair enough. Fair enough. So I think in the trial, 40% actually had, what was expected is 40% will have a CPS score more than 10. The standard first line treatment of PDL1 positive metastatic NBC involves chemotherapy plus an immunotherapy agent, and with a median progression-free survival of nearly 9.5 months. And upon progression, one half do not go on to receive second line treatment. This actually came as a surprise to me. Dr. Suman, is this your attrition rate when somebody has a metastatic TNBC? Only 50% of them actually go on to second line?
No, I don't agree with this. This is not real world data. They may change the doctor because, usually failure of drug means it's failure of doctor, in Delhi at least. But they will definitely go for a second line. So I think almost all go to a second line treatment. So I don't agree with this attrition.
Fair enough. Shefali, how many patients of Dr. Suman have you seen?
Very difficult to answer. So I agree with Dr. Suman. I would not say all go to the second line, but of course majority will go, because in TNBC the risk is basically the brain and the fulminant visceral progression sometimes, and if they fail on the first line standard of care, that is the major issue. So, however, the younger, because these are the younger, fitter patients who have a TNBC majority. So, most of them in a good health or good PS would go for a second line treatment. 50% is too high, not getting a second line.
Yeah, even I thought that it was too high, and I came across this trial. I think this was presented in ESMO Breast in 2025, where they saw that the attrition rate was only 10%. However, note that this is not in TNBC, this is in all patients, and only 10% of them had TNBC. But I think 50% seems to be too high in their background. So SG basically is a TROP2 directed ADC approved for patients with locally advanced metastatic NBC after at least 2 prior lines of treatment, out of which at least 1 should be in metastatic setting. So if you look at it, this was the ASCENT trial which resulted in SG getting its approval, more than 2 lines of chemotherapy. Then they gave either treatment of physician's choice versus SG, and they found a PFS difference 1.7 versus 5.6 months. So the research suggested that there was synergy between immunotherapy and ADCs, resulting in improved efficacy. So if Chetan, if you can go through this and explain how actually ADCs help in immunotherapy.
Hello.
Yes, Chetan, we can hear you.
Can you please repeat the question? I just lost you in between.
Okay, so basically I wanted you to explain this slide, how ADCs combine with immunotherapy to improve the, basically act in a synergistic manner.
Wow. I've never used this combination, so I won't be able to.
Okay, Dr. Suman, can you just explain how SG works along with immunotherapy, or any ADC for that matter?
So I think the concept is that ADCs go directly into the tumor and release the chemo component, which causes a increased immunogenic response, and it brings in all the T cells into the tumor. And what basically the synergy with the immunotherapy is that, you are enhancing, you are removing the brakes over the immune response, and you're enhancing the immunity. So both work in enhancing the immune response against the tumor. I think that's why they are synergistic, and that's the concept of combining.
Yeah, fair enough. So I think there are now quite a few studies to suggest that ADCs combined with immunotherapy makes it a better synergistic mechanism rather than only chemotherapy with immunotherapy. So this was the trial where patients with previously untreated TNBC, PDL1 positive more than 10%, and were taken up for chemotherapy plus pembrolizumab versus SG plus pembrolizumab. So the prior anti-PDL1 therapy was allowed in the curative setting. So the chemotherapy options were paclitaxel, nab-paclitaxel, or gemcitabine plus carboplatin, and the PFS was the primary endpoint. So Shefali, in your clinical practice, what are the top 3 chemotherapy regimens you use in TNBC?
So platinums, of course, are the preferred choice, then taxanes included. And after that, I mean, I tend to use capecitabine also, much more in these kind of patient in metastatic settings.
So your top 3 would be a single agent platin,
Yes, sir.
taxanes, and
Platinum,
capecitabine.
taxanes, and depending if I want a more robust response rate only with the chemo, then combination chemo with taxanes and platinum is my choice.
What about anthracyclines?
Anthracyclines, sir, I tend to use in triple negative, but not a preferred choice here, considering the response rate was almost, I mean, even better with the single agent carboplatin and taxanes.
Fair enough.
So, yeah.
Prabhat, in TMH, what are the top 3 or 4 chemotherapeutic drugs you use? TNBC.
Yeah, as my previous panelist said, Paclitaxel is obviously first choice in metastatic setting. Capecitabine, simple, easy drug, oral drug, and AC and Gemcarbo are the other options.
Yeah. Chetan, are you surprised by the fact that nearly 50% of them got Gemcarbo and taxanes or Gemcarbo were the main 2 options?
No, I think taxane and carbo are the standard option. Basically, some form of platinum and the partner sometimes changes from either taxane to a gemcitabine is probably what they were. That is why they have used this combination. In our practice, it is anthracycline. Then before gemcitabine, I try to push in eribulin if feasible, and then the others.
So just to put it across, taxanes were given as single agent. Only gemcitabine was allowed with the carboplatin. So I was a little surprised that taxanes were always single agent and carboplatin, whenever given in this trial, was with gemcitabine. So I think you have answered the usual chemotherapeutic drugs which you prefer. And this is the PFS.
Sir, if I may interrupt,
Yes,
would you be happy or would you agree with the trial designs to re-challenge with immunotherapy? I don't practice besides breast GI, so I'm not sure. In other cancers, is re-challenge an option? I mean, I would be happy if work, then it will work for life. And if it did not work, then it may not work.
Fair enough.
What my
I will
concept
come
is.
to that question. It is there in the next slide.
Sorry.
Regarding the issues, regarding the progression-free survival, Prabhat, what is your take on this PFS curves?
So PFS curves are separating. Obviously, more responses are seen, is what we can see from the curves, and it is sustained over a period of time due to immunotherapy component with added with ADC. So it seems impressive.
So seems to be impressive. So these are the differences in terms of PFS, duration of response. The response rate seems to be nearly the same. The adverse events are okay, and treatment discontinuation is also less with the SG plus Pembro compared with the chemo plus Pembro. These are the toxicities. Chetan, you told me that you have not used this drug. Prabhat, by any chance in TMH, have you used SG?
Yes, sir, in relapsed refractory patients. So I will not comment much whether they are toxicity due to multiple lines or due to the drug itself.
And what has your experience been? What are the main toxicities?
Neutropenia, sir.
Okay, and what do you do for that? Do you give prophylactic PEG GCSF or GCSF, or you only treat it when it happens?
I treat it when it happens, but next time secondary prophylaxis is given.
Fair enough.
But not only GCSF, not PEG GCSF, because it is day on day regimen.
Any other toxicity in terms of nausea, vomiting? How aggressive you need to be?
Not as compared to TDXD. It is less nauseating regimen compared to TDXD.
Fair enough. Dr. Shefali, have you used this drug?
No, sir. I haven't used.
Dr. Suman?
Yes, I have used it myself, and then of course my colleagues have also used it, the team that I work in. So we have at least 10 patients we have used it on. Neutropenia is our greatest problem with the patients. We use prophylactic GCSF, but despite of using that prophylactic GCSF, we have had cycle delays. So it is not exactly, probably like Dr. Prabhat said, I don't know whether it is per se just the drug or because these are patients who have already received multiple lines of chemotherapy. So we currently we have used it in this third line. So probably they have already, the marrow is exhausted, but neutropenia is definitely an issue. Fatigue is a big issue. And I guess nausea, we anyway treat it like a highly emetogenic. So we do give good antiemetics for it. Diarrhea is definitely an issue. I'd not come across anybody with grade 3, but grade 1, grade 2, yes, they do have.
Yeah, I think because this drug, most of us have not used it. So that is why I wanted the experience of people who have used it. Like I think Dr. Prabhat said, the chances of serious adverse event leading to stoppage of the drug is extremely rare. So neutropenia is a black box warning, and we need to be aware of that. Diarrhea can be quite severe. So there was a pooled analysis trying to see whether patients from Asia were, had a different toxicity profile compared to the Europeans. Chetan, did you see this presentation, or what is your thought about the toxicity in Indian or Asian patients compared to European patients? What do you expect?
I expect the drug to be better tolerated by Asians.
Okay, so basically, it seems that the treatment-related adverse events are quite similar in Asians as compared to the Europeans. They used primary GCSF prophylaxis, and neutropenia, anemia, leukopenia was slightly higher, but diarrhea, like how we saw in few of the other drugs, seems to be less common in Asian patients. So I think I'll not go into this. So they concluded that SG plus pembrolizumab demonstrated a statistically significant and clinically meaningful improvement in PFS from 7.8 to 11.2 months, and no new safety signals were seen. I'll just go to it previously. I just wanted to let you know, I think Prabhat made a point. I think that is not there now. I removed that slide. But if you look at this trial, less than 10% actually received immunotherapy upfront. It is here now. Prior anti-PD-1 or PD-L1 therapy, only 4 patients received. So, Prabhat, can you just comment on this?
I'm okay, sir. Only 4% have received.
Yeah. Only for a very small number actually received PD-1 therapy in the adjuvant setting or neoadjuvant setting. And I think that raises the question, if all our patients nowadays triple negative, or at least we hope, get immunotherapy in the neoadjuvant therapy, in neoadjuvant setting, how much of this trial actually has implications going forward? Suman, your thoughts on that?
I don't know. I really don't know, because I feel I mean the trial results look very promising for a space where nothing really works. You're just buying little by little, few months and sequencing it, and basically we are just giving one regimen after another to increase the PFS. I mean, giving them little by little, few months each. So I don't know. I hope that it does work in the context of us using Keytruda in the adjuvant setting and then re-challenging it. But until and unless we have a clinical trial, we wouldn't know. But we are hoping and betting on the fact that in an adjuvant setting, it gives you a longer survival. So you don't really come to the point of metastatic setting.
Fair enough. So the next trial of importance, or
Just to, sorry to interrupt, but for my knowledge, is it re-challenge in any cancer anywhere, any trials that because I have concentrated only in 2 diseases, so I'm asking. What will others say? Will we be happy?
Sorry. Go ahead.
RCC, we are doing it.
Yeah.
But I think there is
RCC and melanoma also.
Yeah, I think a recent study in RCC, in fact, 2 studies were presented recently in ASCO, I think, where it was clearly proven that, or clearly found that, a re-challenge with immunotherapy in RCC is not useful, unless, of course, you have a patient who has received immunotherapy long back. So I think there are 2 studies in that. I'm not able to remember the studies offhand, but one study presented this year and one more study presented last year. Both of them showed clearly that there is no point in continuing immunotherapy or re-challenging it in the short term, at least. So the
So the
next
concept
trial,
that if immunotherapy works, then only to be given. If not working within few years, not to give again.
yes, of
Holds
course,
true.
that trial did not answer that because there were not many patients who were rechallenged, say, after 2 years or so. So it really did not answer whether that small group of patients who were treated with immunotherapy, say 3 years back or 2.5 years back, would benefit. So coming to the next trial, the Ascent-03, this is actually not presented in ESMO or in ASCO. It has come as a press release from the company. What they showed is basically they released is that the study was in patients with first-line metastatic triple-negative cancer who are not candidates for checkpoint inhibitors. Basically, they are either PD-L1 negative or are ineligible to receive immunotherapy. We don't know the further details because it's only a press release. And they claim that it is a positive trial with significant benefit in terms of progression-free survival. I just put it in context that SG probably will come in a big way in first line. And I think with help from Amol, it is the top cited study in this year. So if you look at the next one, when SG is there, this is a new drug called sacituzumab tirumotecan. I think when we all heard of Sunil Gavaskar for so many years, we need to see that we will have some replacement for that. So ST is now the new drug. Basically, we know that TROP2 overexpression is there, and that is why the anti-TROP2 ADC is used. This is a new drug with a different payload, which is an inhibitor of topoisomerase 1. And this is a single-arm study, phase 2 study, wherein the primary endpoint was overall response rate and the second endpoint was PFS. Seems to be that 70% was the response rate, and it was 72% even when the PDL1 was less than 10%. Similar to the SG, ST seems to do its job like what we saw so many years ago. SG and ST seem to be doing the same job. So your thoughts, Prabhat, do you think that we are going to end up with more and more ADCs?
Yes, sir, I agree. More and more ADCs is the way to go forward because you can give more amount of drug and less amount of toxicities are seen because of their and targeted nature.
Yeah, so probably this Optitrop Breast 05, we will learn more about it and we'll hear more about it in the near future. Shefali, your thoughts on this drug?
Absolutely, sir. And if we use it in earlier lines, I think we are more decreasing the toxicity concerns also. So 70% response rate is something which is impressive. Of course, the more mature data will lead us to the first line option there in PDL1 negatives.
Yeah. So then I come to the fourth trial. So I discussed two trials. One is actually we are presented. The other one is a press release, both on SG, and one drug, the new drug called ST. Now coming to the fourth trial, this was, I think the sixth best drug here, but it became sixth best because there you can see that there is absolutely no negative comment. I don't know whether Amol commented on it or not. This is a trial with absolutely no negative comment, even though it was only 64,000 views. So this is a study evaluating safety and efficacy of ivermectin in combination of balstilimab in patients with metastatic triple-negative breast cancer. Basically, Suman, can you just throw some light on it? Did you see this trial by any chance?
No, I read it. This is the first time I'm hearing of this trial. Ivermectin, I mean, I do know that people have used ivermectin in brain tumors, but I don't know. I have nothing to comment on this.
Chetan, any thoughts on this?
No, not really. I've never used either of these drugs. But ivermectin, they are trying it in everything. Probably the triple negative is low hanging fruit where nothing works, no target. So that is why it was a big thing during COVID. But and there are always somebody on Twitter keeps on posting something about ivermectin. So it will be a interesting thing to see how it pans out. Right now, I will just hold my comments.
Yeah,
And,
maybe some immunomodulatory effect, which is leading to the add-on the immune checkpoint kind of phenomena to be
yeah,
enhanced. I think that
basic,
should be the fundamental behind it,
yes,
basically.
you are absolutely right, madam. Basically, this is a small study. Only 9 patients were accrued, and only 8 were evaluable. 1 had stable disease, 1 had progression, and 6 had 6 had progressive disease, and 1 had partial response. Basically, the combination seems to be well tolerated, and this is what happens when you give ivermectin. There is somehow a immune cell death. Once the cell dies, the cancer cell dies, it releases antigens, and probably it helps in immunotherapy. So, Prabhat, your thoughts on this ivermectin? Are you doing any trials in Tata with this?
No, sir, not yet.
I was just wondering whether we can use this not only in breast cancer, but probably in something else when you're using immunotherapy. So,
Sure, sir. We can try, obviously, but giving immunotherapy alone was a bad idea, is what I felt while looking at 9 patients' data. Only 1 had PR, 6 had PD. So they should have given something else also.
And without chemo.
Yes, yes. This is in patients who had 1 to 2 prior chemotherapies only, and ivermectin was given for 3 consecutive days, and then there was a gap of 4 days. In the 21-day cycle, it was given in groups of 3 days, 3 times. So the last study is in metastatic breast cancer, was presented basically in ESMO Breast 2025. Basically, I think Keytruda has gone so far ahead, and Atezo is just trying to catch up somehow or the other. So this is from the EL1 SAR trial. Basically, it's a phase 3B study of first-line Atezo plus nab-paclitaxel for patients with PD-L1 positive triple negative breast cancer. We know that we already had a trial, the IM Passion 130, then we had IM Passion 131. Basically, this included little bit wider range of patients. They did treat patients with selected autoimmune diseases, stable CNS metastasis, and little bit poorer performance status. So what happened is when they did that, it seems to be that the response of the median progression-free survival seems to be around 7 months, and 27 months seems to be the overall survival. Chetan, your thoughts on atezolizumab in metastatic breast cancer?
We had that talk yesterday that I somehow feel we really don't know where exactly Atizo works. In places where it works very well, it does work wonders. But in triple negative right now, all my immuno is only pembrolizumab and not Atizo.
Fair enough. Suman, your thoughts on Atezo in metastatic breast cancer?
Like Dr. Chetan said, actually, we had this discussion yesterday also. And for me, I think atezolizumab is like giving water. I'm sorry to say that, but it just doesn't work here. And first, there was a positive trial, then it followed by a negative trial. And honestly, in real world also, it doesn't work in triple negative. Even our own clinical experience has not been, I mean, people have failed very early on. So I don't believe it works. So for me also, like Dr. Chetan says, the IO to go to is Keytruda, pembrolizumab.
Shefali, you also believe it is water, or is it tonic water?
So whatever name you name it, sir. So I think I don't use Atizo in breast anymore.
Fair enough.
KP, ask Sendil. He's there.
No comments.
Prabhat, I just wanted your thoughts on this. 67% was the concordance between local and central PD-L1 testing. Now, this came as a little bit of shocker to me. 67% seems to be a small number. Do you think, we are doing PD-L1 left, right, and center? We don't know what we are doing sometimes. What has your experience been in Tata? Do you think do you repeat the PD-L1 testing in Tata if it has been done outside?
Sir, sometimes we do repeat. Considering HER2 experience with HER2, even now that HER2 is also not what has been there outside. So PDL1, if I got shocked, I will not say, but now thinking wisely, I feel if HER2 can be wrong even till date, then why not PDL1? Once you said 67%, I was shocked.
Yeah, so we know about this. People are passionate about atezolizumab, but whether you are passionate 130 times or 131 times, it seems to be not that great a drug. It seems to be that pembrolizumab should be the way to go if you're thinking of immunotherapy in TNBC metastatic setting. So there were a lot of debates on why 130 and 131 were different. And now we know that atezo approval has been withdrawn. So I think we'll not go into that. Finally, coming to this, line diagram on how to treat advanced TNBC, SG has come in such a big way that it seems to have entered the guidelines, or it will enter most of the guidelines very soon as first line in patients who are PDL1 positive, rather than giving pembrolizumab plus chemotherapy. If PDL1 is negative, I think all of us would give chemotherapy and look at the germline mutations, BRCA1 and 2. And by any chance, if it is positive, that would be our second line PARP inhibitors. And if it is negative, then we start looking at other things, whether the HER2 is low positive or not. And if it is negative, again, if you have not used SG upfront, that would be the way to go. I would all the four panelists their final comments on what they think is the any new changes in metastatic breast cancer or what they are looking forward to. Chetan, will start with you.
Chetan.
Yeah.
Yeah. So anything you are looking forward to happen in the metastatic breast cancer scenario is the question KP asked.
Yesterday, there was some data about TILs that would be, in the metastatic setting, maybe we can pick up responders versus non-responders. That sounded interesting. And of course, sacituzumab, tirumitecan, they are coming out in a big way, not only in breast. In fact, there is also a trial in cervical cancer now. So that drug also sounds a good bet, impressive response rate. That would be something to watch for.
Actually, Sachin Tendulkar or ST is playing for China actually, and it is approved in China for quite a few diseases. Suman, your final thoughts.
I think advanced TNBC is a space which we still need good drugs. So I'm excited about the prospect of SG being there, ST being there. I mean, ADC is coming in, and probably we needed stronger drugs to tackle this disease. But as Dr. Chetan said, and as we discussed yesterday, I think probably biomarker driven and selection of patients, probably a more finer selection than what you have shown. If we could, really handpick our patients, because there is a lot of money involved in these treatments. So we could predict a better outcome upfront.
Yeah, excellent points, Suman. Shefali, your final thoughts?
Sir, I think it would take a lot more time to bring them into real world practice. As Dr. Suman also mentioned, still, I mean, the financial toxicity is too much to consider here. And since if we see the urothelial also, EV is there, still we are not able to use it. I mean, if it's in that way. So I think, I mean, guideline wise, it is okay to have them. They are impressive, but real world scenario, it will take time to imbibe them in our real world.
Prabhat, your thoughts?
Sir, SG plus Pembro, now that you have shown this slide, TDXD gives 12 months PFS in such setting also. So before that, I was impressed with the data. Suddenly, after looking at your slide, if HER2 low, I may, and patient has, if he finances, then maybe I will leave for second line, ADC for second line with TDXD rather than using SG as first line therapy.
Fair enough. So I think we have had a good discussion. I thank all my panelists. I think we hope that SG will work well, but like how everybody says, your drug will work very well only if you use it. So with that, I thank my panelists and thank Dr. Sahu for this opportunity and hand over the mic to him. Thank you.
Thank you, KP. I always feel that I don't know what the Hindi will be. KP when he moderates, there's like a therao. He just cools down the whole scenario. Just That's a very laid back thing. KP, thank you once again. You always do a brilliant job. I'll take one question from the panel. Any one of you can take up this, Prabhat or Suman or Shefali or Chetan, whoever. There's a question on the Q&A. What is your opinion on targeted probiotics with immunotherapy? Anyone who has worked on in this field, has read this field, can volunteer to take this question.
So you are asking about the
probiotics
dysbiosis
with immunotherapy.
Oh, okay. So, sir, I mean, not a great experience with so many patients, but generally, I tend to use them once the side effect profile or the diarrheas are intolerable. Even I tend to use sometimes in my chemotherapy patients also on this, and I think these work well. So probiotics, I mean, I am on the side of using it actually.
Dr. Sendil, quick one-liner for this.
I don't think we can indiscriminately use something like that, Sahu. Microbiota transfer is a big science by itself, and there's a lot of study that's going on in microbiota transfer. So it is much more complex compared to just using a probiotic. I think we should leave it at that, because getting
at
into
this point we don't have enough science to do it on everything.
there is emerging science to do it. There are some early phase studies in lung cancer which have shown that it's much better than using just pembro alone in patients who are PD-L1 more than 50. So there are smaller phase 1-2 studies which are going on, but it's not easy to do it. Scaling up to the community is not easy, and so on.
That's one. On daily practice, you would not do it.
It is not. No, not just a probiotic. I think that's making it too simple.
Yeah. So last question on the Q&A before you take on for the last one, Dr. Sendil. I want you to answer that. The question is very clear. Two part of it. Keynote 522 regimen. We are talking the new adjuvant. Dr. Savinay has asked, should we be adding GCSF to chemoimmunotherapy regimen, or would you reserve it for someone who has developed a febrile neutropenia in the preceding cycle?
I think we wouldn't use it prophylactically. Okay. So if somebody whose count is dropping and would, preclude us from using the chemotherapy on time, then we would use immuno. Then we would use.
That was easy. Second one was, would you be confident using 522 with weekly paclitaxel instead of the 3 weekly?
In fact, that's what we do. We use paclitaxel weekly only. It's not 3
so
weekly.
People do use it. And the last one is, if you have not used the immune checkpoint in the frontline metastatic TNBC, you achieved a CR or a near CR, let's say a very PGPR, and you have done pacli carbo, would you choose observation, or would you go for the early second line without evidence of progression? Like
I wouldn't. So there is data in TNBC that if you use some maintenance therapy, your PFS and probably OS is also likely to be a little better. So I tend to use something as maintenance therapy. Most commonly, what I use is capecitabine if I've used pacli carbo. Sometimes I do carboplatin maintenance. So I try to keep patients on some drug rather than stopping it completely, because there's some evidence to say that that might be a better strategy to follow.
Okay. So I think we will take Dr. Sendil's talk now and have two more questions which we'll answer at the end of it. So Tarun, you have raised your hand for any particular reason? Tarun?
No, sorry, sir. Yeah,
okay.
No.
So I think this is the last talk of the 2 days deep dive into breast cancer. What we made to think, the trials that has made us think twice. Game changers in ASCO 2025. So let's now hear Dr. Sendil. What are his top picks for what we have heard in ASCO 2025 for breast cancer, the field of breast cancer? Dr. Sendil.
Good evening, everybody. Thanks, Sauku, for asking me to speak again today. Trials that made us think twice, controversial or game changers in ASCO 2025. And I'm sticking to breast cancer only because this program is all about breast cancer. I'm going to try and play the devil's advocate rather than just saying that all of these are practice-changing studies or game changers, as a lot of us would actually think or accept it to be. So I've got 4 or 5 studies. Sahu, as usual, can you warn me 5 minutes before my time so that I will wind up, because this can go on endlessly.
Yeah, we are the last one. So we have time till 9:30.
Okay. So I had a chance to listen to Amish's animated discussion on Destiny Breast 09. So let me give you my take on Destiny Breast 09. So this is a first-line metastatic HER2-positive breast cancer study. TDXT plus placebo, TDXT plus pertuzumab, and the standard Cleopatra arm. These were the 3 arms. the results for TDXT plus placebo are still not out. So the comparison or the readout was for arms 2 and 3. 6% had brain metastasis, 30% had PIK3CA mutations. They were trying to look at the prognostic value of PIK3CA. It's associated with poorer prognosis. And they were trying to see if TDXT would overcome that. It actually did. Chemotherapy was given for about 6 to 8 cycles in most patients, but can you believe that some patients went up to 51 cycles of chemo and 42 cycles? That's docetaxel and paclitaxel. Imagine 42 cycles of paclitaxel. For me, that is a little too much. 54% of patients were HR positive, and this is typically not a set of patients that we would see in the first line, especially if those are the relapsed set of patients. Only half of them had had trastuzumab earlier. Only 15% of patients had had pertuzumab. Now that reflects the multi-center, multi-country kind of study that Destiny Breast 09 was. About half of all patients were from Asia. And this clearly reflects the point that Asian patients don't get whatever within inverted commas is standard of care. The other major negative issue with Destiny Breast 09 is that endocrine therapy was given only in 13.5% of patients in the TDXT arm and only around 40% of patients in the THP arm. That's a little ridiculous in my mind. Even if we were not doing patina, patients in the Cleopatra arm should have gotten hormone therapy if they were ER positive. So just 40% of patients getting hormone therapy there when 54% were actually ER positive is again something that is not the best of designs as far as my opinion is concerned. This is the PFS curve. Amish actually showed you the investigator assessed PFS. The Bicker assessed PFS is actually the primary endpoint. There you're getting about 27 months of PFS for THP, which is much more than the 18 months that you get in Cleopatra. I think the reason for this is probably because of the addition of endocrine therapy in about 40% of all patients. Nice, clear, early separation. The delta is 13.5 months, almost 14 months. That's really good. The overall response rate was 85 versus 78. The complete response rate was much higher in the TDXT arm. Now, one of the things that we would have liked to see is if this drug prevented patients from getting brain metastasis, something like lorlatinib in ALK-positive lung cancer. We just don't have any data of whether there was CNS protection or not. There were 6% of patients who had inactive brain metastasis when they were enrolled, but we would have loved to see this data. We just don't have that. The overall survival is immature, but there is a trend, as always, in favor of TDXT plus P. As I remarked earlier, not all patients got hormonal therapy, and in today's day and age, patina would have been standard of care. None of these patients actually got patina, and I'll come to the relevance of that a little later. Now, 40% and 30% on the respective arms did not get any subsequent therapy at all, which I think is also a little higher compared to what you would see in the clinic. The PFS2 is more in favor of the TDXT arm, but that's not statistically significant as of yet. Again, a point that was discussed during Amish's discussion, only about 10% of patients in the THP arm got TDXT on progression. Now, again, that reflects what is practiced in most parts of the world where you don't have access to TDXT for various reasons. Now, if more patients got TDXT, there's a high probability that this PFS2 curves would actually come together. And I'll show you some numbers that I kind of put together to reinforce that particular fact. AE-related discontinuations were 1 in 5. Patients decided to discontinue 11%, and there were 3.9% deaths. Not all of them probably related to TDXT. What's important also to note that is the average time that patients were on TDXT is about 21 months. Now, remember the PFS for TDXT arm was 40 months. So half of these 40 months, these patients were actually not on TDXT. So a data that I would actually like to see is what is the PFS compared to patients who continue to take TDXT versus patients who actually discontinue TDXT? Because one of the ways of thinking about this drug, which is terribly toxic and expensive, is can you just use it for a period of induction and then continue only the pertuzumab or trastuzumab, pertuzumab, some kind of treatment like that? Because all patients who discontinued TDXT got trastuzumab. So they didn't go just on pertuzumab, they had a combination of trastuzumab and pertuzumab. So it will be very interesting to get this data, this 20 patient, the set of patients who discontinued versus set of patients who continued. Was there any difference in this particular number? And that would add a lot of credence to the thought, and also some of the studies which are going on, which are just looking at TDXT for a short period of time and then continuing only H and P. Something that all of us are very interested in, interstitial lung disease, that's about 12%. There were no grade 3, grade 4, 2 patients had grade 5. So my thoughts on DB09. Is this a first-line option? Absolutely, it's a first-line option without any doubt. But am I very impressed? I'm actually not. I expected much more than what you're seeing in terms of these numbers that I have shown. Now, for people in our country, is a sequencing strategy acceptable? I think it's very much acceptable. I put some numbers together here. Let's take a patient with HR negative disease. If you had Cleopatra plus DB03, 67% of patients in the DB03 had T plus P. So that would be 18 months for Cleopatra. I'm not putting the DB09 number, that will be about 26. So 18 months on Cleopatra plus 29 months, which is the median PFS for TDXT in DB03, you get 56 months. You got 40 months with TDXT. What would you do in the second line? You would do tucatinib trastuzumab. What's the PFS for tucatinib trastuzumab capecitabine? It's 7.5 months. So you're going to reach nowhere close to this 56 months when you use TDXT first line. I'm just putting some numbers together. There are a lot of problems like, when you do calculations like this, but this is just to put a thought. If you've got a HR positive patient, Cleopatra plus Patina followed by DB03. So 48 months, 44 months was the PFS in Patina. I'm adding 4 months for the induction THP plus 29 months for DB03. You get to 77 months. Okay, 40 months, whatever you put after that, I don't think you're going to get to 77 months. But there are problems when you sequence, there's attrition, CNS failures, blah, 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 and so on and so forth. But this is just some food for thought for people who think that DB09 has simply smashed everything away. I don't think it has done. For me, actually, it's a little bit disappointing. The questions that I will actually like to know is CNS failures. Can we stop the drug early? What's the contribution of pertuzumab? I don't think it's it would have made a big contribution. I hope I'm wrong when the TDXT arm only comes. Is toxicity a concern? Absolutely, yes, yes, and yes. Would discontinuation be an option at some point in time? Maybe. Do we have any biomarkers? We just don't have any biomarkers. So for my take, I think it's a practice-changing study, but is not as practice-changing as all of us would have liked it to be. It's a little disappointing for me. We move on to Serena-6. So these are the two controversial studies, DB09 and Serena. Serena, everybody thought was hands down a winner, but the discussant was so superb. If you have a chance to listen to that discussion, I think every one of us should listen how to do a discussion of a paper. So Serena, I think Vamsi did a good job, and I think the conclusions that he drew and his panelists drew were absolutely correct. So what did they do here? After 6 months of a patient being on a CDK4/6 plus an AI, they randomized patients based on the appearance of an ESR1 mutation, but you don't have radiological progression. Okay, so if you have an ESR1 mutation, you would get a scan done. If your scan is showing that you've got anatomic or radiological progression, then you go out of the study. You can't get randomized. If you don't have a radiological progression, then you're either randomized to camizestrant or you just continue on the same arm. So it's camizestrant plus continuing a CDK4/6. It was placebo controlled, or continue the same AI plus CDK4/6 inhibitor. Palbociclib was the CDK4 inhibitor in a lot of patients, but there were patients on ribo and abema also. PFS was by investigator assessment was the primary endpoint. So what did they try to look at in this study? They were trying to test two hypotheses. One, if you treat at molecular progression, will you delay the emergence of resistance? So you're treating early, so will you delay the emergence of resistance? Two, if you do a molecular switch and at the time of molecular switch you change over, will you be able to prolong survival? So these were the two questions that this study actually asked. Again, as Vamsi rightly pointed out, only 1 in 6 patients that you would see in the clinic will be eligible for a strategy like this. So how many patients are you going to test? How many times are you going to test with the expense of Garden 360? I think we will just go bankrupt to start with. This study started with 3,256 patients, got 548 that they could randomize. Somewhere around 319 or something like that were actually randomized finally. Okay, so look at the logistics involved. That's number one. Number two, investigator assessed PFS 16 months versus 9.2 months. So for the patients who had camizestrant change based on molecular progression, had a better PFS compared to patients who were continued on the AI plus a CDK4/6 inhibitor. One good thing about this is that the deterioration in global health status quality of life was vastly superior for patients who changed early, 23 months versus 6.4 months. So that's good. The PFS2, which is supposed to be a better surrogate for overall survival, was better for the molecular switch therapy compared to continuing on the same, but this was not statistically significant at the time of this readout. So PFS2 is not yet statistically significant, but you see that there's a nice separation. Let's spend a couple of minutes on this slide. This is a slide that I borrowed from Dr. D. Michel, who did a superb discussion of Serena-6. I put the two hypotheses at the top. One, molecular switch will delay resistance. Two, molecular switch will improve overall survival. So let's start this way. Now, if you say that molecular switch is going to delay resistance, you should clearly show that patients who switched early to camizestrant had a longer PFS compared to patients who took camizestrant or a SERD and continued that CDK4/6 plus CDK4/6 inhibitor. So if you add this PFS, which is 9.2 plus this PFS, this should be shorter. Or the other way of saying it is, if you switch to camizestrant early, you should have a longer PFS for camizestrant compared to this plus this. So let's again draw some numbers. Serena-2 ESR1 mutant population. If you took camizestrant in that, you got a PFS of 6.3 months. So if you add 9.2 plus 6.3, that comes to almost the same as what you're getting with switch to camizestrant early. So you should have clearly shown that camizestrant early is going to give you a longer PFS compared to switching at the time of clinical or radiological progression, which we have not shown, at least in this trial. If you wanted to show that all patients who progressed on the arm 2, which is AI plus CDK4/6, should have gotten camizestrant at the time of progression, that would have been the fair way to do this study. Give all of them camizestrant at the time of progression and show that the PFS number 1, which is camizestrant continuation or giving camizestrant early, will give you a longer PFS, which they actually didn't do. Point number 2, in this study, is PFS2 going to be a good surrogate for overall survival? The answer to that question is no. And why is it no? Because let's look at a patient in the real world. You start here, the aromatase inhibitor, you switch early. So that is first line therapy, that's second line therapy. Here, this continues to be first line therapy. So in the test arm, you've actually changed 2 treatments, while in the control arm, you're actually changing only 1 treatment. So if you're comparing switch of 2 treatments to switch of 1 treatment, that is actually not PFS2. I don't know what to call it as, but that's actually not PFS2. So in Serena-6, PFS2, in my mind, is unlikely to be a good surrogate for overall survival. Only 10% of patients in the test, in the control arm, actually got camizestrant. So you've got less patients who got camizestrant. You've got imbalance in terms of post-progression therapy. So when you have both of these and you're not controlling for your post-progression therapies, it's extremely unlikely that you're going to be able to show that PFS2 is a good surrogate for overall survival. So for me, Serena-6 is not a well-designed study because they set out to answer two very important questions, but they didn't design it appropriately to answer both of these questions. And that's where the problem arises. And then comes the huge costs of testing large numbers of patients. And if you switch early, obviously you're going to give them longer duration of camizestrant. So who goes happy? There are two people who go happy. One is Guardant, the other is camizestrant. I don't know whether your patient is going to be happy at all. Improvement of time to deterioration of quality of life was significant, but the question will be at what cost? So for me, Serena is a good hypothesis generating study, but has it proved the point? I don't think it has proven the point. We then go to something that all of us can apply finally in our daily practice. This is called the NeoCarb study. All of us have problems using carboplatin along with docetaxel, paclitaxel, whatever it is. It adds to thrombocytopenia, myelosuppression, more toxicity. So the question that these Chinese investigators actually asked was, could you drop the carboplatin completely? So they looked at a non-inferiority study where they randomized patients to THP. So that is either paclitaxel, docetaxel, or nab-paclitaxel for 6 cycles Q3 weekly versus taxane, carboplatin, trastuzumab, pertuzumab into 6 cycles again Q3 weekly, and then took them to surgery. The primary endpoint of this was a 10% pre-specified non-inferiority margin. They fixed the PCR level at 62.8. So if you got a 52.8 with the THP, the lower limit of that confidence interval, this would be a winner, and it did win. So 64.1 versus 65.9 was the PCR rates. We clearly understand this is a surrogate endpoint, but I think it clearly tells you the activity. I'm not too sure we should wait for relapse-free survival or overall survival when the PCR rate is absolutely bang on the same. The lower limit of that confidence interval is minus 8.5. You're fine with minus 10. So I think it seems to be safe to be able to omit carboplatin in patients with stage 1 and stage 2. This does not apply to stage 3 or stage 4 patients. The other study, which also reported some early results or interim results, is the COMPASS HER2 study, which again did not randomize patients, but they did look at PCR. This was only 4 cycles of THP. That's 6 cycles. This is just 4 cycles, and you got a PCR of 43.8, which is quite low compared to what the Chinese guys got with 6 cycles. But the point here is that there seems to be a set of patients who don't need carboplatin. So my thoughts on this is, can we avoid carboplatin with HP? Yes, for stage 1 and stage 2 disease, weekly Taxol is preferred. I'm not having the time to go through those details in those graphs. Should it be 4 cycles or 6 cycles of THP? I think if it is stage 1, some of us tend to do stage 1C. You tend to put these patients on neoadjuvant. So if you are a group which belongs to that category, then 4 cycles of THP should be enough, is what I feel. But if it's for stage 2, then I would think of 6 cycles of THP. I would omit the carboplatin. Do we know why the Chinese study showed more PCRs? Maybe 6 cycles. There's data to show that nab-paclitaxel actually does much better compared to conventional paclitaxel. Do we know why weekly paclitaxel was superior to docetaxel? We just don't know. Can the same be true if dual HER2 is not used? Now, this applies clearly only when you're using dual anti-HER2 therapy, not for trastuzumab only. In the context of dual anti-HER2 therapy, is the question of anthracycline becoming more and more irrelevant? I think the answer is yes.
Can you hear us?
Pardon me? The world seems to have moved on beyond anthracycline. So I think it's losing its relevance progressively. Can this data be extrapolated to T3-4N2? The answer is no. So I think this is something for me was very impressive and something that all of us can use in our practice for selected patients, stage 1 and 2, not for everybody who walks in. Krishna Prasad did a lovely discussion of ASCENT. I really don't have too much to add to. I'm just showing you the curves here. Early separation, again, there's a delta of 3.5 months, PFS 11.2 versus 7.8. In the box at the top, I have put the keynote 355. the numbers that made us accept Pembro as one of the treatments along with chemo for patients who had a CPS of more than 10. Look at the numbers, just absolutely bang on, except that the 7.8 that you're seeing in the study seems to be a tad lower than the 9 months that you got in the 355 study. But if you look at the hazard ratio, it's absolutely the same 0.65, 0.66. For me, the overall response rate is though not very different. You look at the progressive disease rates. 4% on SG plus Pembro compared to 12% on chemo plus Pembro. So, that's something that's very important for patients with large volume, large burden, triple negative disease. Interestingly, the toxicity of SG Pembro was much better compared to taxane and Pembro. What's the other interesting thing here? Beautifully, the trial itself had put in a situation wherein all patients who progressed will get sacituzumab at the time of progression. Something that you don't typically see in pharmaceutical sponsored studies. And I think we should give full marks to the sponsors of these studies for the sake of doing something very brave like this. Because if you do something like this, what is likely to happen is that the overall survival is likely to be blunted by this, this crossover to SG. 81% of all patients who had any subsequent treatment after discontinuation of chemo plus Pembro received SG. I don't think you will even get something like this in the real world. In the real world, you get 50%, not more than that. In a trial where crossover is not allowed, at the maximum, you would get 25-30% who get SG. Look at this, 80% got SG. I don't know whether you're going to be happy seeing something like this. Obviously, as some clinician who practices, you're going to be happy the way the trial was done. But is Gilead really going to be happy? I'm not too sure, because tomorrow people will say, since SG done later is also going to give you better outcomes, why not sequence it rather than doing SG at the beginning? That's something that's open to discussion. If we have time, we can do that. Again, Krishna pointed out during his discussion, only 5% of patients had been exposed to an immune checkpoint inhibitor in the adjuvant setting. But over time, with Keynote 522, you will see that more patients will progress after an immune checkpoint inhibitor. Is this a good way of treating those patients? I leave it to you to decide. 18, 30, and 33% would have relapsed at the first, second, and third year of 522. Now, so you will have about 30% of all your patients who would have been exposed already. Is this a treatment for them? When would you expose them? 6 months later, 1 year later? I think these are questions open. What about sequencing one ADC after the other? It doesn't seem to be a great thing to do, just like one immune checkpoint inhibitor after the other doesn't seem to be a great thing. The same thing seems to be happening here. One ADC after the other. Look at the PFS, 2.83, 3.5 months, hardly anything. So it doesn't seem to be a great strategy unless we learn what the reason for the resistance is, and then we are able to clearly say, this is the mechanism of resistance, so this is what you should be doing as your next line therapy. So my thoughts on ASCENT-4, is ASCENT-4 an important option for first-line TNBC patients? Absolutely, yes. Should we consider it in the first line? I think yes is my answer. The PFS benefit is significant. Lesser PDs, again pointed out during the panel, the discussant said 50% progress. I don't think 50% progress and don't get to a second line therapy. It probably is around 30% in our practice. What about patients who relapse after Keynote 522? I don't think we know the answer to that question. Is the crossover to SG likely to blunt the overall survival? Yes. What if there's no overall survival benefit? Will we throw it out, or we will still say that they did a fair trial and they didn't find out overall survival benefit? Again, we will discuss this when that actually happens. What after SG Pembro? Chemo and targeted therapy, ADC after ADC seems to have very limited activity. We'd love to see what happened to the TROP2 expression biomarker analysis, which is not yet available at this point in time. Another question that I always think is, if somebody comes to you with an ER of 5%, what would you do? Would you do SG Pembro or a different strategy? Again, something that's open to discussion. In this study, you had to be ER 0, PR 0 for you to be randomized. But all of us know that ER low patients behave like TNBC patients and not typically like ER positive patients. Sahu, I think I'll stop there. I've touched 30 minutes.
If the people are ready, take that. I think I'm loving it at least.
You're loving it? Okay. Since you're organizing loving
If anyone
it,
has an objection,
I'll continue to torture for 5 more minutes. This is the last
please,
one.
please.
Okay. Innova 120. Okay. Again, Vamsi did a lovely job. I think I totally agree with everything that everybody said. I was actually doing my outpatient as I was listening to the discussion, but it still was very much worth it. Again, these are a set of resistant patients randomized to Inavo plus Palbo plus fulvestrant versus placebo, Palbo plus fulvestrant. Investigator assessed PFS was the primary endpoint. PIK3CA mutation had to be tested by Foundation 1. Okay, that's fine. At least some of us on and off will do Foundation 1, though most of us would do some home-brewn PIK3CA analysis. But this is what they did on the study. There were patients with primary and secondary endocrine resistance. Okay, this is the secondary endpoint, which is overall survival. The overall survival was better by about 7 months. Good, but I would not say great. 0.67 is the stratified hazard ratio, which is quite healthy. 15 and 25% on placebo got either a PIK3CA or an mTOR targeted therapy in later lines. Most of them got chemo in the second and third lines. Okay, so very few, rather one out of 6 or 1 out of 4 only get some targeted therapy that they should have gotten or they are supposed to get. So that's a kind of an imbalance that's probably contributing to this overall survival benefit. If at least half of all patients got a PIK3CA targeted therapy, would you see this overall survival benefit? I doubt very much, but that's food for thought. This is the updated PFS. So two things I want you to notice here. One very important number is the time to first subsequent therapy, which is much longer for the Inavo arm compared to the placebo arm, 7 versus 17 months. So these are the other secondary endpoints. I just want to put this in perspective. So this is the updated PFS that I'm showing you here. I'm sorry, that's not the time to first subsequent therapy. The first time to first subsequent therapy is on the right side, the box that I'm showing you here. So it's 3 times higher for the Inavo arm compared to the placebo arm. So 12 months versus 36 months. So I think that's clinically very, very important. The delta for PFS is very similar to what you got in the first line data for patients with CDK4/6 studies. That means AI plus CDK4/6 versus AI, 14 versus 24, 25 months was the PFS difference. So you're seeing something very similar to that in terms of the magnitude. In fact, the hazard ratio for the first line studies is 0.56 compared to 0.42 here. So if you're cross comparing studies, Inavo seems to be a reasonably good option. Again, look at the response rates. 28%, because it's a PIK3CA mutated population. Your CDK4/6 does not do a great job, because otherwise in all your first line studies, the response rate is somewhere around 56-60%. So it's half of that. And the PFS is also half of that, So all of these numbers, I think, are quite significant. In our country, hyperglycemia is going to be a problem. Patients who receive more than one concomitant medication for hyperglycemia, 40% of all patients. So you can just double it if it comes to an Indian population. So that's going to be a major challenge. So this is my last slide. So my thoughts on Inavo 120. Is it an option for hormone therapy resistant PIK3CA mutant MBC? Yes. What are the clinical significant endpoints? For me, the overall response rate, because it's 3 times the PFS, because it's a 10-month difference. The hazard ratio is 0.42. There is an overall survival benefit, though I would say that's not very impressive. The time to next or the first chemotherapy, which is 3 times on the Inavo arm compared to the standard arm. Would we have liked to see a better CDK4/6 inhibitor? Yes, I would love to see either abemaciclib or ribociclib. Abema would not be a great drug to combine because both of them have diarrhea as an overlapping toxicity. Ribo would have been a great drug. What about patients who progress on the adjuvant CDK4/6? Less than 5% of patients in this study belong to that category. So we just don't know when you can re-challenge patients with the CDK4/6 inhibitor. Again, just like Keynote 522 versus Ascent, you got the same problem between Monarch, Natalie versus the Inavo 120. Can we use alpelisib instead of inavolisib? I don't think We should be doing it at this point in time. Very few patients receive PIK3CA targeted therapy. Can be sequenced? Looks like it's not a bad idea to sequence, but if you can lay your hands on Inavo, I think it will be, it's not a bad idea to do it upfront. But patients with high sugars can be quite challenging. So one needs to be very careful when you're doing something like this. So I will stop here. Sorry for exceeding my time, Sahu, but since you said, okay, I tend to go on. Thanks so much. If there are any questions, I'm happy to take them.
Anyone wants to ask a question? Because we have only those who are interested. So
we have only people who don't want dinner here, it looks like.
Amish, you're not there. Okay, so
Amish is
yeah, 1 minute.
Yeah, I know you will
How can
ask.
I not ask?
I really want
Amish is pulling up some energy, it looks like.
So, PFS2, Senthil.
Yeah.
I always get confused about the PFS2, and since I'm awake and I'm still in the clinic,
so you're eating, so you should be awake.
Two thoughts. I thought PFS2 told us about the sequencing. That is the first thing what it told us. Whether first followed by second is better or second followed by first is better. Second, it tells me that when I give something first, does it impact the subsequent response? But you mentioned about the OS. Just help me understand a little more.
So the reason why we are, you're partly right, Amish, but the reason why we are doing PFS2 is not because we want to learn about sequencing, because in a situation where the time from the first PFS to death is quite long. Let's say this classic example that we started with for this kind of a strategy is the first-line CDK4/6 inhibitor studies. The overall survival is 60 months. The first PFS is about 24 months. So you're spending more than half of all your time on a different treatment. Cleopatra, 18 months on H plus P, and then you end up dying somewhere at 56 months. Right? So in situations like this where there's a lot of impact on the overall survival with subsequent therapies, we said, okay, let's not only look at PFS1, let's look at PFS2. And there's a large meta-analysis done with somewhere around 32,000 patients, which shows that the correlation coefficient for PFS2 with overall survival is much stronger compared to PFS1. So that is the reason why we use PFS2 as a better surrogate for overall survival compared to PFS2. But you're partly right, because it also, to a certain extent, answers the question of sequencing. Suppose you sequence it, which is exactly PFS2, and the PFS2 is not significant, then it's very unlikely that the overall survival is going to be significant. So that's the science behind doing PFS2.
I got it. Sorry, Tarini, before you ask, I want to ask one more question. Sorry. Senthil, SN04. In your conclusion, you mentioned that, it is definitely can be looked at practice changing, if I was correct, right?
Yeah, you're right. Yeah.
Okay. Is it in all comers? Because that is something which I have my doubts. So, for example, germline BRCA mutation positive. Or something like, you have any other mutation, because TNBC is going to be biomarker driven in future. So can we say SASI plus Pembro is going to be in all comers?
I think if you make a simple interpretation of the study, Amish, I think the simple answer would be yes. Okay. Trial was positive. It seems to be benefiting all comers. There doesn't seem to be one group which seems to be more or less or whatever it is, except that 5% patients who had a immune checkpoint inhibitor in the adjuvant setting, they actually didn't benefit, but it's a very, very small number. Okay. Saul is rightly pointing out the first criteria will be that you should have a CPS of 10 or more. Okay. So that's certainly a criteria. But it begs the question, okay, suppose you have somebody with small volume disease. You were drawing the analogy of HP versus H only. If you just had lymph nodal disease, would you do it? So I think we will ultimately learn to do that. But for me, at this point in time, if you ask me a simple interpretation, should I do it for everybody? I'll just say yes. And then maybe we can look at dissecting the data to see whether some patients benefit more or less and so on.
Okay.
So I have to stop this. Every good thing has to end. So, and thank you, Sendil, boss. I know that you will do a good job of the last lecture. And I would like to thank all the panelists, all the faculty, all the discussants, especially Tarun. He really pushed me to do this. And I really want to thank, if I miss someone, please forgive me, but it was lovely to have you for 2 days. I have learned a lot. I don't know about others, and I would love to do this after 6 months. I need just the support and help of everyone to agree to what they have done this time. So thank you all. Good night. Stay safe. And I don't know whether COVID is re-emerging or not. So yes, we will be getting a record of this, but I will just delete Sendil's last lecture because I don't want anyone who has not attended to benefit from that. Jokes apart, I'll do that. So Tarun, last thing, and then we move on.
No, so finally, sir, thank you so much for this excellent 2 days, I think, scientific extravaganza with a lot of people joining. Definitely, we will be ready with the recording in the next 15 days. And on behalf of both of my colleagues, RM, Yashika, and thanks support for everyone. Till we say goodbye to everyone, stay safe, stay blessed. Good night till we meet again. And please mark your calendar for Deep Dive ASCO 2025 for lung cancer, 18th and 19th June. Thank you. Good night to everyone.